Okay, good morning. Thank you so much for joining us today. I want to start by thanking you.
Bye, sir.
Morning. For that passion, I keep seeing the passion for gathering knowledge and skills, and it's really very motivating. So thanks to all of you. Today we are going to look at assessment and physiotherapy management of spinal cord injury. And as usual, before we start, I just want to give a little background of the past modules that we have done, because that's going to help us to situate whatever it is that we want to do today within the bigger picture. It was deliberate that we started with the first module looking at principles of assessment and management. So in those principles, we looked at a lot of neurophysiology and neuroanatomy, and that's for us to be able to understand the locations of parts of the nervous system that helps to bring about movement. I remember in one of the workshops that we had some times back on, I think the one that we did in this series, this year, was systems review. And in systems review, we tried to look at the body of knowledge of the physiotherapist. And we said it's about motor impairment, motor function, or the human motor system. We talked about kinesiopathology and pathokinesiology. So we looked at the anatomy and physiology, neuroanatomy, neurophysiology in the first module of this particular series, so that we'll be able to understand the different parts of the nervous system that work together to bring about movement, because that is what is within the scope of our practice, the human motor system. We looked at the brain, the spinal cord, and the peripheral nervous system. And we saw how each part contributes, looking at, for example, sensory information picked up from the body. So, for example, location of the object that you want to interact with. I said the information will go through the optic nerve, and it will go to the back of the brain, which is the primary visual area. But we also said for the individual to be able to move, the brain needs to know the position of the body in space. So if, for example, is the hand that's going to reach for an object, or for example, the leg wants to kick a ball, for the brain to compute what movement should occur, the brain should know the position of that body part in space. And we said that information goes to the brain through the proprioceptors that pick the position of the body in space and sends it through sensory nerves peripherally that go to the spinal cord. And at the spinal cord, it ascends through the posterior column of the spinal cord. It goes up to the somatosensory area of the brain. And when it goes to the somatosensory area of the brain, then it now goes to the prefrontal cortex, where that visual information about location and nature of the object have all converged. And that is when the prefrontal cortex in the front of the brain will make use of that two information, synthesize them, remember the last activity they did similar so that they can bring out the blueprint that was used in the past that was corrected, the errors were corrected, so that there will be more accuracy in the activities. We talked about how this will now help in selecting a pattern of movement that will do the activity, how the premotor cortex and supplementary motor area will give all the different patterns that are possible, how the basal ganglia will give, the basal ganglia will select one out of the many patterns that are available, and the cerebellum will now give an information about the timing of each of the component of the pattern of the movement selected by the basal ganglia. After that, then the motor area, or the pyramidal cells there will fire and send impulses down through the spinal cord, corticospinal tract in the spinal cord, that will now go down, and at each level of the spinal cord, there will be spinal nerve roots that are going to leave the spinal cord, and those spinal nerve roots will now form a nerve. You will have a motor coming from the anterior part of the spinal cord and a sensory that is going into the spinal cord. So because motor is going out, sensory is coming in. But at least as this one is coming in, as this one is going out, they are going to meet somewhere. And where they both meet is called the plexus. The plexus will now give rise to individual motor and sensory nerves that will now go to the muscles, the motor nerves, while the sensory will go to the skin and the joints and other places. Of course, as we discussed this, we should also remember that as these nerves are going out to go to muscles and skin and other parts of the body, there are also nerves that are innervating the organs in the body. So the lungs, the heart, the GIT, and other organs of the body. And they live at the same levels. If you remember when we did systems review, we talked about shared pathways, that you can have referral of pain if nerves that are living at the same level.
If
the
we
motor
have
nerve and the nerve that supplies the organs, you can have one refer pain to the other. This is one of the principles of referred pain. So these are just a few of the things that we discussed during that first lecture. I'm saying this because we are now going to be using those principles as we discuss a spinal cord injury. Another thing we discussed, I believe during that first lecture of the series also, was the issue of the syndromes. And I remember myself and Dr. Lawan, we discussed partly each looking at when there is an injury at every level, what are the expectations? We started by seeing some of the tests that you do to be able to know the difference between upper motor neuron and lower motor neuron. This also is important and applicable in this lecture that we're going to have. So if you have, for example, you do the reflexes and you have hyperreflexia, it's going to be an upper motor neuron. And if it is hyporeflexia, it's going to be a lower motor neuron. If it is flaccid, possibly lower motor neuron. If it is spastic, definitely upper motor neuron. Why I said possibly for flaccid is because you can have a brain or spinal cord injury that at the early levels, you are going to have flaccidity because of what is called shock or spinal shock. We are going to discuss that at some point in time. The issue of atrophy. In lower motor neuron, you have atrophy, but not in upper motor neuron lesion, the Babinski reflex, and a number of other tests that you do. But most importantly, it's good to remember that when you look at the upper and lower motor neuron, or the central and peripheral nervous system, Now, we said the central nervous system is what is in the brain and spinal cord, except cranial nerve nuclei and anterior horn cells, which are not part of the central nervous system, even though they are in the brain and the spinal cord. So don't count the cranial nerve nuclei and the anterior horn cells as part of the central nervous system. They are part of the peripheral nervous system, even though they are located in the brain and the spinal cord. So now that we are dealing with spinal cord injury, let's focus more on the anterior horn cell. The anterior horn cell is in the spinal cord. All part of the spinal cord is central nervous system, but not the anterior horn cell. So the anterior horn cell, the nerve roots, the plexus, the peripheral nerves, the neuromuscular junction, and the muscles themselves all form part of the new peripheral nervous system. Therefore, if you have an injury that affects the anterior horn cells in the spinal cord, you are going to have flaccidity, you are going to have atrophy, you are going to have hyporeflexia, and other features of lower motor neuron lesion. But if you have an affectation of the spinal cord that affects other parts of the spinal cord, not the anterior horn cells, then you are going to have the other features of upper motor neuron lesion. But you can have an injury that affects both the anterior horn cells and other parts of the nervous system, and then you are going to have a mixed presentation. And one of the conditions that will usually have those mixed presentations is called the amyotrophic lateral sclerosis. But that's just by the way. We are dealing with spinal cord injury now, but it's important to know its different parts and the implication of injury to one part and not the other. We are going to look at that using a diagram or a picture, and that will be clearer. So I'm just trying to bring back what we did earlier, looking at the syndromes. So when there is a problem in the upper cervical, what happens? When there are problems at different levels of the cervical, sorry, the spinal cord, what happens? We are going to see in more detail those issues. We're also going to look at assessments. And those assessments will cut across ICF domains, that's to say impairment, activity, body function and structure. Let's look at the positive side, body function and structure, activity, and participation level. We will look at assessments at those three different levels. But apart from that, we're also going to look at the different domains of impairments that we can have: motor, sensory, balance, and ambulation. All those things, we will look at them. Of course, we are not expecting any cognitive problem. Remember, we said that when we took history during systems review, and also the last one we did with stroke. Unless you have an injury or disease in the brain, you are not expecting to have a problem with cognition. And therefore, cognition, as a result of spinal cord injury itself, not a secondary problem or an underlying disease or injury separate from the spinal cord injury, you are not expecting cognitive impairment. And therefore, we are not going to deal with that today, because we are focusing specifically on a patient that has spinal cord injury. We're also going to look at management, but I realized last week it started to push a lot, and there was no time because there are so many things to deal with. And this time around, I'm going to change the approach. And what we're going to do is because we did evidence-based practice as a workshop, a whole day workshop. We also did clinical reasoning and decision-making. And then we did all these reviews and preliminary workshops just to be able to help us to understand a lot of what's happening, so that when we come here, we don't have to present everything. So what we are going to do today is much more of an interactive session, so that we'll use examples that will help us to be able to understand how do we search for the information, how do we extract it, how do we use it, so that at the end of the day, even if we are not able to cover all the things about assessment and management that we need to do, at least people will be able to go back and apply what we have discussed and learned in searching and applying for information that we are not able to cover today. So today is going to be, there is going to be a lot of interactions to do things together, so that we can be able to understand the parts that we are not taking today, how do we go away and cover them on our own? That's the active learning principle. So thank you so much, everyone, once more. This is just by way of introduction and recap of what we have done in the past few weeks. So at this point, I'm going to open the floor for discussions, just maybe 2 to 3 minutes, just like we did last week on stroke. What outcome measures? Let's start with outcome measures before we go to management. What outcome measures do you usually use? So we are talking of the ones that you use, not the ones that you know, but you don't use. You have patience because how does our practice change as a result of attending the workshops that we attend? So I would like to have more focus on the ones that we use. So this is what I use in assessing my patients that have spinal cord injury. So let's use the chat forum. If anyone wants to raise their hand, I will allow them to speak. But if not, use the chat forum just to post the type of outcome measures that you use in assessment of your patients. ASIA, wonderful, very good. ASIA, good. Okay, okay, SCIM, wonderful. Okay, any other ones? I remember I said the ones that we use, not the ones that we know we should use, the ones that we use. Okay, any other ones? Look, I can see 2, ASIA and SCIM. Yes, SCIA, so it's like majority use or Oxford Muscle Grading Scale. Yes, okay, good. MPRS, okay. SCIA and Frankel, yeah, right. Okay, so can we have one of those, because ASIA is one of the most common that people have reported using. Can someone, not through the chat forum now, can someone, ROM, yes, can someone speak to, just in summary, about its use? So just in summary, how is it used in the assessment? What does it assess? And how is the assessment done? And then maybe another person can discuss how we use it in the management of the patient. So I would like to see hands because many people really said they use it. So how do you use it? What does it assess and how is the assessment done? Good. Innocent. I got you. Yes, unmute please and speak.
Good morning, Prof.
Good morning.
For the Asia,
yes,
I do use Asia in the clinic too. So for Asia, for example, for a patient that came to our clinic that has maybe a brain injury resulting as a result of a traumatic brain injury, or have a upper cervical kind of injury that may have affected the head too. So we use Asia to analyze them. For Asia A, we have a complete motor and a sensory loss. We want to know whether the patient even have a motor component or sensory component, but for Asia A, we don't have that one. There's a lot of both motor and sensory loss. Then for Asia B, sensory is actually present, but motor is not present. Then for Asia C, sensory is present, motor is present, but the motor that is present is less than the power of that is for major muscles. The kind of parts of the body we're actually looking at. So the major muscles that are there, the power is less than 3. Then for Asia D, there is sensory present, the muscle is also present, but not as Asia E. There's a slight difference between just this that Asia D and Asia E. For Asia D, the power, the major muscles that are there that we are assessing, the power is not up to that of 5. Say if you are putting resistance, let's say highest minimum resistance. Then for Asia E, there is sensory is present, motor is present. The motor is not actually that. If you check, maybe for example, the segmental muscle assessment, not that the muscle will be highly, let's say, if you put high resistance on it, maybe the highest resistance you put on it, that the muscle, you can grade the muscle like 5. But what I'm saying is that it's normal, but not like somebody like me now just walking on the street right now. Like the muscle power is as good as mine, but it's normal. That's all.
Thank you very much. Thanks a lot. So what you have given very good is the interpretation and the classification. So you have done the tests and you have the results, and you are using those results now to interpret and make sense of what you have assessed. Remember, we talked about the issue of evaluation. I would say the evaluation is in the interpretation. So you do the test, you interpret. But this is very good because it shows really good understanding of the Asia. Abubakar Yahaya Musa, can you unmute and speak, please?
Okay, sir. Good morning, sir.
Morning.
Can you hear me, sir?
Yes, we can hear you. Good morning.
Okay, okay, sir. So, in a nutshell, ACI is a scale that is used to assess the level of spinal cord injury and its severity, whether it is complete or incomplete, and then it is the method that is used in assessing it is by assessing the dermatomes and myotomes. That's what I can see, sir.
Okay, wonderful. Thank you so much. So that's the first part. You assess the dermatomes, you assess the myotomes, and then you use that to do the interpretation that was given very beautifully by Innocent. So thank you so much to the two of you. Very good attempt to put the two together and gives a bigger picture. I'm very happy that people are using the Asia, many people, because I can see many people saying they use it. And from what I've just heard, people don't just know it, but they understand it and are applying it, which is very good. So we're going to discuss more about it. And then how do we now make use of the results to now plan for the management of the patient. So we are going to do this. So thank you so much. So let's just go to the slides. I've shared it. I hope you can all see it. Okay, so let's just have a very brief introduction. When you have neurological damage to the spinal cord due to trauma, so say the sensory and motor affectation is below the level of injury. Yes, okay, that's a good one. That's a good one. So we'll see that when we do the assessments. Using the Asia, not long from now, we'll do that. Thank you. Yes, so males aged between 15 to 25 years are more at risk. Yes, so they are males and also their age. These are risk factors for a spinal cord injury. So most do not involve transection of the spinal cord. So it's not that there's a complete transection, but the problem is that there's secondary vascular and pathogenic events. So you're going to have an inflammatory process as a result of the injury to try to protect the system. And that will now lead into temporary loss of information passing down or up. And that sometimes you might even think that there is complete paralysis, but at some point, after some days, when that primary, the edema, the pathogenic vascular or pathogenic events have been resolved, you find out that movement now begins to come back. So it's important to take note of this. That it's not all cases of spinal cord injury that will lead to complete paralysis, even though at the early stage, it might appear to be so. This is a little review of anatomy. I'm not going to discuss this because I know it's very basic, but it's important to know because whatever presentation you are going to have is going to depend on those structures that are affected. So in the central nervous system, the spinal cord itself, and also the issue of the nerves that leave or enter the spinal cord, and they enter or leave through the roots. And that is why it's important to understand the roots. You have 31 pairs, 8 cervical, 12 thoracic, 5 lumbar and sacral each, and 1 procedural. So very important to take note of that. And another important thing, because you are going to have injuries that affect the anterior or the posterior or the sides of the spinal cord, that anteriorly you have motor nerves leaving the spinal cord, while posteriorly you have sensory nerves entering the spinal cord. So very important to take note of that. Now, this is a very important picture. Look at this. You are going to see some very, very interesting things. Remember, we said in assessments, you assess proprioception and touch. So light touch and also crude touch. So there are different areas of the spinal cord that those sensory nerves for such sensations pass across. And therefore, the affectation of different parts of the spinal cord will lead into different presentations. That's number one. Number two is the issue of decussation. At what point in the spinal cord do those nerves decussate and move to go up to the brain? So that also will determine what presentation you will have depending on the injury where it affects. So if someone has a knife and they injure you through this side, and it now affects this part of the spinal cord, then the presentation you are going to have will depend on what structures are there. If it is anterior affectation, it depends on what structures are there. The same thing with the other side and the posterior part. So it's very important to note what positions these structures have in the spinal cord. Very important. So this is the presentation at the anterior. So this is the anterior. This is the anterior. Sorry, this is the anterior. This is the anterior, and this is the posterior. So this is the posterior where the sensory information pass across. But there are some levels of overlap that you can have something that seems to be a sensory information can still have a place in the anterior part. Remember when we discussed the reticulospinal, vestibulospinal, and what have you, that we said mostly they are not under the voluntary control of the brain. And we said if this information passes through the posterior, they pass down to the anti-gravity muscles. So for example, visual system sense to see if your head is moving towards the ground or the other way around. So the visual system can send information directly without going to the cortex, to the reticular formation, and from there you can have reticulospinal tracts going down to the anti-gravity muscles to make the anti-gravity muscles to contract to keep the person in a normal erect posture so that they don't fall. The same thing with the vestibular system. If the head rotates and the head is rotating down, meaning the head is going towards the ground, then the vestibulospinal tract through the vestibular nuclei will begin to send impulses down to the anti-gravity muscles. The same thing with proprioception. You are going to have, I think, the tectospinal tract going down from information that comes from the proprioceptors. For example, in your ankle, if you have proprioceptors and you begin to sway forward or backwards, that information goes, and then through extrapyramidal tract, it sends impulses down. But one good thing about the nervous system, just like we have in the brain that you can have redundancy, there are some cells in the brain that are redundant like spare tires, that if some cells are dead, other cells can take over the function of those cells. So in the nervous system, there's a lot of that. So if you're having a problem with the corticospinal tract that sends motor impulses down, if you're having a problem with that, there could be an alternative. of any of those other extrapyramidal tracts that can do that function, so that at least the person will have some level of movement, even if they can't have it as they used to have it in the past. So very important to take note of these things. And therefore, you can see overlaps in the position of these tracts and these areas of the spinal cord. So as I've said, this is the posterior, and therefore you'll have sensory information that is picked from the sacral area. It is more medial, so very important to take note of that. It's more medial, followed by lumbar, going lateral, and then thoracic region, and then the cervical region. And remember, there is what is called white and gray matter, where the gray matter is where the cells are, because just like this, you have a cell, and that is where you'll have a synapse. But you now have the nerve, axon of the nerve that leaves the cell. So usually where those axons are those areas that are called the white matter, and the gray matter is where the cells are located. So you have sacral, lumbar, thoracic, and cervical. So this is how, and this is called the gracile fasciculus and cuneate fasciculus. So this is where information about proprioception and light touch. So the position of the body in space, you have the proprioceptors in the joints of the body. So for the legs, they are going to go through the lumbar region. For the upper limb, they are going to go through the cervical region. But it is about that proprioceptive information that goes through the posterior part of the spinal cord, and then it ascends up and goes to the brain. We are going to discuss at what point they decorsate. That is what is going to determine when you test the right side and you see a problem with proprioception, or you notice or you record a problem with proprioception, you'll be able to know what side is it that is affected from your measurements, or when you look at radiological investigations and you see the affectation, say, in the right side, you'll be able to know on what part of the body that you are going to have the manifestations. So this is important to take note of these things. Now, you have also spinocerebellar tract. So from the spine, the posterior, it comes through the spinal cord and it goes directly to the cerebellum. Remember, we said the cerebellum is the one that gives timing to each component of a pattern. And this is not just before the movement starts, but continuously. The cerebellum does that action of giving timing. It's very possible because of some environmental reasons. The timing for a movement might change during the activity. So this is what is part of the feedback that the nervous system gets to be able to control movement. So if in the in the environment there are reasons to adjust a movement, the cerebellum that gives timing to the components of get information through the spinocerebellar tract that goes up, but it goes to the cerebellum directly to give it feedback on what is happening in the environment, the position of the body in space, and other things that are happening that come from the spinocerebellar tract. So this is the posterior spinocerebellar tract, which is more posteriorly, but also laterally. Posteriorly, but laterally. So posterior spinocerebellar tract. And this is its function, sends information to the cerebellum to help with feedback that helps the cerebellum to give timing to movements. Then you have the lateral spinothalamic tract. Spinothalamic. Remember, we said the thalamus is like a relay center in the brain. So sensory information that is going to the brain will have a relay center, and that is the thalamus. So you have now, very importantly, take note of this, very important. The sacral area is more lateral. The sacral area, very important. We are going to discuss this when we come to the different types of spinal cord injury that we can have and what the presentations will look like. So this is the sacral area. Then next to it, which is more medially, if you look at this, is the reverse. You have the sacral more internally, more medially, and then the lumbar, thoracic, and cervical is more lateral. But that is for the gracile fasciculus and cuneate fasciculus. But for the lateral spinothalamic tract, you have sacral, then you have lumbar, you have thoracic, and the cervical is more medial. The cervical is more medial. Very important, take note of that. And at this level, we are looking at pain and temperature. So pain and temperature. So if you have an affectation that comes from outside and affects more of the lateral part of the posterior end, then you are going to have more affectation of proprioception and light touch at the cervical level. So the upper limb and other areas that are supplied by the cervical region of the spinal cord. So proprioception and light touch. But if you have an affectation lateral, but more to the center, not posteriorly, more to the middle, then you are going to have, if it is much more lateral that is affected, so it's not complete, it does not go inward. So you are going to have affectation more of pain and temperature at the sacral level and lumbar level. So very important to take note of those. So this is the lateral spinothalamic tract. Of course, you have an anterior spinocerebellar. So just similar to the posterior spinocerebellar tract that we talked about earlier, you also have an anterior spinocerebellar tract. This goes to the cerebellum. This goes to the cerebellum. But this one, they go to the thalamus as a relay center before they go to the sensory part of the brain. That is the lateral spinothalamic tract. Please, can we have, I don't know who it is. Okay, Bosley has been, no, still there. Infinix, the person using Infinix. Please, can someone mute him, admin? Okay, so sorry, I had to reclaim and unmute. So anterior spinocerebellar. Now, you have spinothalamic tract, but anterior. This is lateral spinothalamic tract. That is looking at pain and temperature. So it's sending impulses or information up about pain and temperature to the please. Infinix, I keep muting you, but you're unmuting. Please, can you remain muted? Yes. Oh, come on. Please, who is using Infinix X6528? Please, can you mute? Please remain muted. So the anterior spinothalamic tract, which is anterior, you know, even though it's sending sensory information about crude touch, but it is located anteriorly. And what it sends is crude touch. So you have light touch when you use a cotton, as you are doing the assessment, you use a cotton and the patient feels it, it goes through the gracile fasciculus or cuneate fasciculus. But if you are using a pinprick, the patient feels it, the information is going up through the anterior spinothalamic tract. So we also have the anterior corticospinal tract, which is more medial than the anterior spinothalamic tract. So this is where you are going to have on this side, the anterior corticospinal tract. So the corticospinal tract is a descending tract from the motor area, which is the pyramidal area of the brain, the primary motor area. So this is where information descends to go down to the muscles. So that's the area. And this is just showing that you have the cells in the gray area while you have axons in the white matter area. Infinix, I think I'm going to remove you for now so that you can be back later. Okay. Okay. Yes, so sorry, I'm taking a lot of time to explain this because understanding the structures and where they are is necessary for the understanding of the manifestations that we see. And the understanding of the manifestations we see is a key to what treatment we give. We have gone beyond giving general package of treatment to every patient. The presentation that we see in patients will determine what treatment we give. I remember when we dealt with stroke, we said the location of the injury or disease will determine what interventions you give. If you have a peripheral structure affected, you are thinking more of strengthening exercises, electrical stimulation. Also, if you are looking at the central area, especially the brain itself, then you are looking at more of things that will facilitate neuroplasticity. And very importantly, it has been discovered recently that neuroplasticity does not only take place in the brain. You can have neuroplasticity in the spinal cord. And therefore, if you have spinal cord injury that affects ability of information to come from the brain, passing through the spinal cord to the periphery, in as much as it is a central nervous system problem with upper motor neuron lesion, then you can give those interventions that usually are given to the brain to facilitate information passing across. You can give them motor imagery. Very important. I've used it. I said it last week. I used it in a patient that had cancer that metastasized to the thoracic level, and there was no movement. But after the motor imagery and functional electrical stimulation that we did, at some point, movement began to come back because it was not an injury that they had complete transaction, and therefore the prognosis was very poor. No, the moment he gets radiation therapy or whatever treatments that he gets for the cancer, and you get the you do your test and see that cancer level has gone down, and then you see movement begin to come back after these interventions are given. So if you go and just giving electrical stimulation, you are not going to see the movement, but just motor imagery. Usually what I do is just put that video with someone moving, but you can't see the person. I say, assume that you are the one moving, and he's watching it over and over. You also do functional electrical stimulation, apply, you see movement, and you see. So if you don't know the area that is affected, and you don't know the implication of those areas affected, then you won't be able to choose what intervention you give that is going to make an impact in the movement system. So I hope this is clear. Of course, you can see the spinal nerve roots. So at the back here, you are going to have the sensory, and then you are going to have the motor. They come out through the roots, and then they form a spinal nerve. So at this point, it's a spinal nerve. It now goes to a plexus, either the lumbar or the cervical plexus. And then after the plexus, it now gives peripheral nerves that are either motor or sensory. So this is what is going to happen. And that's just a summary of this. Thank you. Yeah. So let's now look at the implications of injuries to these different parts of the spinal cord. Yes. So let's look at the patterns of presentation with incomplete spinal cord injury. That's what is called the sacral sparing. Remember, that's why I said take note that you have the sacral peripherally for the lateral spinothalamic tract. Of course, for this, it is more medial, but this is also the lateral corticospinal tract. Sorry, I think I didn't even look at this. I didn't mention this. You have the anterior corticospinal tract. This is sending down information about motor, but you also have motor here. So here. So what's happening is that in this place is where you are going to have this. They just separate motor and sensory so that it will not be confusing, and they will have space to be able to give this the namings of the different parts. But on this side also, you are going to have something like this on this side. So this one also, you are going to have something like that. on this side. So you have, this is motor, and the sacral area is also more lateral. This is sensory, and the sacral area is also more lateral. And remember, I said if you have an injury that affects this, this is what you, but if you have a central affectation, then you are going to have the cervical, thoracic, and maybe even the lumbar affected, but you are going to have the sacral not affected. So if there is any injury that affects the central part of the spinal cord, then you are going to have what is called the sacral sparing, because this is the sacral area, it is more lateral. So this is what this is talking about. Patterns of presentation with incomplete spinal cord injury. So it's not complete. There are some areas that are not affected. So number one is called the sacral sparing. So peripheral rim of the spinal cord is preserved. So usually vascular injuries are the ones that result to this, and that is why you'll see the problem more centrally than laterally. So small radicular arteries supplying the outer rim are preserved. So the outer rim is supplied by small radicular arteries, and they are preserved when you have vascular injuries. Remember, it's not just the trauma can lead into vascular injuries. I think we mentioned that earlier, that you can still have the trauma, but it affects more of the vessels. So this is still relevant. So you have motor and sensory pathways to the sacral segments remain intact. So when you do your assessments from the Asia that you mentioned, you see that for motor and sensory to the sacral segments, they remain intact. So you don't have problems, say, with voiding and sensation around the area of the sacral area. So patient retains sacral sensation, voluntary anal control. Yes, so I was saying voiding. So voluntary anal control. The patient can control the anus, and therefore they can be able to control void. They may have toe movement because it is from the sacral, that sacral root that supplies the toe. So you see the patient having toe movement, they control they have anal control, and sensation around the sacral area is intact. So when you have this, but you have other areas not intact, then you have an incomplete spinal cord injury that is with sacral sparing. And from the picture that we saw, I think we will understand why there is that sacral sparing. Then you have what is called the Brown-Séquard lesion. Remember when we did the syndromes, we mentioned the Brown-Séquard lesion, that you can have what looks like a hemiplegia or paraplegia, but the problem is in the spinal cord. And you might think that it is a hemiplegia or from stroke or whatever, but the problem is from the spinal cord. It's Brown-Séquard lesion. So one side of spinal cord is damaged. So one side of the spinal cord is damaged, penetrating injuries such as gunshot or knife injuries. So the gunshot, the bullet may pass just on one side of the spinal cord. Or when there is a knife injury and the knife only penetrates through one side of the spinal cord, you can have Brown-Séquard lesion. So now, this is what is important. Remember the positions. I've shown the picture. Remember the positions. When you have one side affected, you are going to have loss of proprioception and cuneatus that we looked at the posterior part of the picture, the sensory, the posterior part. So you have loss of proprioception and motor function on the same side as the injury, and loss of pain and temperature sensation on the opposite side. So loss of proprioception and motor on the same side, because for the proprioception and the motor function, they move on that same side, they reach the upper part of the brainstem before they deposit. And therefore, if there is affectation of that side, it is on the same side, because from the periphery, the nerves have brought information to the spinal cord, and it is still continuing to go up. It is when it goes up to the brainstem, it decossets. That is for sensory. For motor is the reverse. It has already decosseted. It is on this side, and when it gets to the nerve roots, it sends information to the muscles. And therefore, if you have an injury on this side, for proprioception. For motor, you are going to have loss of proprioception, and there should be light touch too, I believe, because light touch and proprioception are having similar case. So on the same side. But for pain and temperature, as they get into the spinal cord, they decorsate. And therefore, if you have a problem on that side, on one side, then you are going to have manifestation on the opposite side, because they decorsate as they enter the spinal cord. So if it comes from this side, the moment it gets to the spinal cord, it's decorsate. So if you have an injury on this side, what is going to happen is that the manifestation is going to be on the opposite side. So this is the concept. So as you assess patients and you now see that the right side is having a problem with proprioception, then the injury is on the same side as the side that you assessed. But if you assess a patient and on the right side you have temperature loss, then your injury is on the opposite side, not the same side of the spinal cord. I hope this is clear, because it's important to understand this. As you may assess patients, you'll be able to know what the location of the problem is, or the other way around. When you look at an image and you see the problem on one side, then you'll be able to know whether the manifestation as you assess it will be on that side or the opposite side. Or when you have a patient that is unconscious, or you have a patient that has cognitive problem. Remember, that's why we said that as physiotherapists, we can look at images and interpret them. For the physician or the neurosurgeon, they are not looking at what we are looking for. What we are looking for is that what might make this patient not to be able to move properly when they regain consciousness, or when the cognitive impairment has been treated. What will make them not to be able to move properly, so that we can be able to address that problem. And if we can't be able to assess, because to assess proprioception, to assess sensation will require the patient to have some level of cognition and to be conscious. When you look at the image of the spinal cord, when you see the injury, you should be able to say that this patient, when they begin to move, they are not going to have proprioception on this side or the other side. So very important for us to take note of this. So most fibers for pain and sensation cross at or near the level they enter the spinal cord. This is what I've explained earlier. Fibers for motor and proprioception cross in the brainstem. So they continue to ascend or descend on the same side until the brainstem. So if it is motor at the brainstem, it crosses, then it continues down. But for proprioception, it's yes, sorry, a call is trying to come in. I had to buy another line to put in a separate phone to use, but unfortunately, the registration did not work well. So sorry. So another presentation is the incomplete, is the central cord lesion. So the central cord lesion. So following hyperextension injuries. So when the patient injury is caused by hyperextension, usually it causes what is called the central cord lesion in the center. So injuries of the spinal at the cervical spine in older people with cervical spondylosis. So when they have hyperextension, so you can have compression, hypoxia, and hemorrhage of the central gray matter of the cord. So peripheral rim remains intact, the same thing as we saw in the first one. So more severe paralysis of the upper limb than the lower limb, because usually it takes place in the cervical spine. Sometimes mixed lesion, depending on whether it extends beyond just the motor area and affects the sensory. So you can have central cord and brown sacred lesion at the same time. So they can present at the same time. But usually it's hyperextension, and in old age, usually is when they have cervical spondylosis. So there's also anterior cervical cord. So that is where the importance of understanding that picture is. Because if you have an anterior, then what is there anteriorly? So remember, we looked at the anterior corticospinal tract coming down. but I think we had the anterior spinocerebellar tract. So those are the manifestations that you'll be expecting to see in the patient. So, and for the anterior cervical cord, usually is a flexion injury. For the central, we said it's extension, overextension, but flexion injury is what usually result to anterior cervical cord injury of problems. It damages the anterior to third of the spinal cord. The vascular insult to anterior cerebral artery, so it's important to also understand the blood supply. Let me check my time so that I will not go and focus on this more than the actual assessment. So vascular insult to anterior vertebral artery, posterior vertebral arteries remain intact. So the posterior remains intact, but it affects the anterior vertebral artery. And since we know where they supply the anterior part, then we are going to have manifestations that come from the anterior part. So posterior columns undamaged. So mostly the sensory, especially remember we talked about proprioception and light touch. They go posteriorly. So you see that are not affected, but motor is affected and spinocerebellar. So you may have problem with coordination because the cerebellum is not getting the feedback that it needs to get. So you have preservation of light touch. Yes, remember I just said it, light touch and proprioception, but not motor function. Pain also, remember, and temperature have some form of spinothalamic anteriorly. So spinothalamic anteriorly would affect pain or temperature sensation. For the motor, it is anterior cortical spinal, which is coming down to anteriorly. So that is what will be affected, sensation below the level of the lesion. Let's quickly look at upper motor neuron lesion and lower motor neuron lesion. So injuries above conus are, we know the conus, lower at the lower part of the spinal cord. Injury above it are upper motor neuron lesion. So spinal cord mediated reflexes intact. So meaning you are not going to have flaccidity, because if you have the spinal cord mediated reflexes not affected, then it brings about, so flaccidity is what you are not going to have. Lesion results in spastic paralysis, so spastic. And this is because the upper motor neuron lesion, it's the upper motor neuron brings down the inhibitory impulses to that reflex. So if you have the reflex itself affected, you will have flaccidity. So maybe let me just quickly explain this. The reflex that is mediated by the spinal cord is the one that has the muscle, the afferent nerve coming to the posterior column. And then from the posterior column, you now have the anterior horn cell, the anterior horn cell. And then from there, you have an efferent, that's the motor nerve that comes from the anterior horn cell to the muscle. So this is a circuit. This is a reflex. So what's happening, depending on what type of reflex we are talking about, if we are talking of tone, or we are talking of tone, then it's like a state of readiness of the muscle, a state of readiness of the muscle. When you touch your muscle, you feel that there is a little tension there. If you touch the muscle of someone that has spinal cord injury that has affected the spinal cord mediated reflexes, you'll see that it's flabby. It's not in a state of readiness. Why do we need the state of readiness? If someone just shouts and we move fast. And when we want to do an activity, we do the activity fast. It's just like a car, you know, an old car. There was a time that I used to use a car that when I come out in the morning, I put it on, press on the throttle, it doesn't move. It will just go off again. So you need to come, put it on, let it warm for some time before you are able to press the throttle and it moves fast. So that state of readiness that you warm it, that's what we usually say warm. I don't even know why we say we are warming the car. So you put it on for 5 minutes and it's then it helps when you press the throttle. So the muscle needs that, because if the muscle is not in a state of readiness to move, when you want to move, the movement does not occur. And that is the tone. So, but there is an inhibitory mechanism that this tracts that we have coming from the brain, one of them will now send inhibition to the muscle to say that, look, I know you are in a state of readiness, but you have the agonist and the antagonist. The one that is going to do the movement in a state of readiness, and therefore it just add contraction to it and it moves. But the antagonist is still also in a state of readiness, and therefore it is contracting. If you don't send impulses to it and say, look, relax, the agonist is doing an activity, so you need to relax. So it's the inhibition that comes to the antagonist to say relax, and it relaxes. And then the agonist now does the activity, and the other way around also. So if you don't have that inhibition coming from the brain down through the spinal cord to the muscle, then you are going to have co-contraction. You are going to have the agonist and the antagonist both contracting at the same time, and movement will not take place. So that is for the muscle tone. And then you have the stretch reflex. Now, this is when someone is trying to move your joint, and as they are moving, there is a stretch reflex, because the stretch reflex is trying to protect you so that someone will not injure you if they overstretch. So the moment you now someone begin to stretch, the stretch reflex will just come into play. And what is happening is that the person that is trying to move cannot be able to move because there is that contraction as a result of the stretch reflex. But the moment you look at the person and you see someone that is not going to hurt you, they are going to just drag you towards some place, then the brain will send impulses down to the stretch reflex and say, look, relax. This person is not going to injure you. Inhibit the stretch reflex, and then the stretch reflex will be inhibited, and then you can move. And that is why when you come to move a joint and you find that it's stiff, is because that inhibition is not coming down to the stretch reflex and asking the stretch reflex to relax. And that is why many people have asked, and I think someone from last week's lecture was saying, what can we use that will be more effective for spasticity? And I couldn't explain fully last time. That is why I'm taking more time now to explain this concept of tone, state of readiness, and the stretch reflex. When you give, say, ice locally, what it does is that stretch reflex, or the muscle tone, the reflex of the muscle tone that they call the reflex arc, it just slows it down. It's just like when water is boiling, you put it inside freezer. The cold nature of it will calm it down, and it's to stop boiling and making that noise. So that's what it does. But the moment you remove it and you put it back on fire, it continues. So what is a permanent solution? You need to give an intervention that is going to target the brain and facilitate the brain to send inhibitory impulses. Because in as much as the inhibitory impulses are not coming down to that reflex, it will continue to be jacking. And activity will just be there, and it's sending impulses from the afferent to the efferent to the spinal cord to the muscle. It keeps circulating, it keeps going around. That is why if you cut the peripheral nerve, or you injure the anterior horn cell, or you injure the peripheral sensory nerve, the whole thing goes quiet and you have flaccidity. But in as much as it is intact, anterior horn cell intact, if efferent, which is the motor, is intact, the muscle is intact, the sensory nerve is intact. If that cycle is intact, that activity will just be there. So the brain will not send impulse to it and say, relax, calm down. But if you have a problem in the brain, which is central nervous system now, or it is not in the brain, but it's in the spinal cord, but it's also an upper motor neuron, not anterior horn cell, but the other parts. If there is an injury there, the inhibitory impulses will not come down, and that activity will continue. So if you want to give more effective treatment for spasticity, because that's stretch reflex that we're talking about, so what you do is to give something that will go to the brain and facilitate for the inhibitory impulses to now begin to come down to stop the reflex. And one of those that do that better than what we have been using is functional electrical stimulation. So functional electrical stimulation. Of course, if you look at the current interventions. You might see things like maybe transcranial direct current stimulation or transcranial magnetic stimulation. There could be those that are going through research that they have shown that they are promising, but maybe they have not completed the researches on them. Possibly there are some that have been completed. I haven't had the time to review them recently, but I know I've checked in the past that there are a number of them that have shown to be promising in helping facilitate the inhibitory impulses to come down to the reflex arc or the stretch reflex. So that is what will be more permanent going forward to help patients with spasticity to have a relief in the spasticity. I just hope that this helps. It's more of neurophysiology. Myself, I'm trying to understand more of it, but that's just the basic principle. So injuries above the cornus are upper motor neuron lesion, meaning you'll have spasticity, and the concept is what I've just explained. The exception is when you have extensive ischemic damage that affects the anterior horn cells over many segments. Now, this exception, you know, when you have an injury, remember last week, we discussed the issue of the perilesional area. I would say this is the area that is damaged, but the perilesional area has edema because of inflammation, and after some time, it will resolve. And when it resolves, that area will now begin to have its function. So if you have an injury that affects the upper motor neuron, but because of inflammatory processes, you have ischemic damage, temporary or some ischemic damage at the level of the anterior horn cells. Remember the arc that I talked about, the reflex arc. One of the components is the anterior horn cell. And if the anterior horn cell is temporarily affected by the ischemic damage or by inflammatory processes, when you are supposed to have spasticity, but because the anterior horn cell that is part of the circuit has been disrupted, then you are not going to see that activity, and you now have flaccidity. And it is at a later stage when the anterior horn cell, either the ischemic damage or the inflammatory processes that have affected it have been resolved, then you now come back to have a complete cycle, and then you now go back to spasticity. And that is one of the reasons why at the beginning of patients having injuries, you can have flaccidity, and then at a later time, it now reverts to become spastic. So these are temporary issues that have happened, but over time, when they resolve, then you now change from the flaccidity back to spasticity. So for example, a patient with a motor C6 level may have lower motor neuron damage of the C7 and or C8 myotomes, but upper motor neuron damage of all other myotomes below the level of the lesion. So that's from what I've just explained now. So type of motor neuron lesion has implications for spasticity and bladder, bowel, and sexual functions and the use of electrical stimulation. So you can't just go and be given electrical stimulation when the patient is having a problem in the central nervous system. No, you can't. If you are going to use electrical stimulation, then it has to be functional electrical stimulation. But if it is peripheral, you have the anterior horn cells, you have the roots, you have the peripheral nerves, the spinal nerve, plexus, peripheral nerves, the muscles, all those are peripheral. Electrical stimulation might be helpful. Electrical stimulation requires intact lower motor neuron. So if it is not damaged, then it can be sending impulses and it's going to make it stronger. That's what ES does. So let's see some other organic pathologies that can come with the injury. We have looked at sensory, motor. This is within our domain. So what are other, so what do you call, we have seen many of these things that we'll see now. We have seen them in system review, and it's important for us to be able to identify them. Either our own treatment will help prevent them, or when we see them, we can refer to the physician. So one is vertebral damage and instability. So this is an organic pathology. When you have vertebral, we'll discuss spinal shock. You don't have to worry. It's part of what we're going to discuss now. So structural damage and instability of the vertebral column. So when you have ischemic injuries, present with no vertebral instability or damage. Patients mobilized within few days of injury if medically stable. So you need to know. And that is where image, your ability to understand image will help you so much. Because if it is a vertebral instability, you can't mobilize the patients just after getting the injury. So ischemic injuries present with no vertebral, patient mobilized within few days of injury, if medically stable. So they don't have any other medical problem, you can. But those with instability may require immobilization for a period of 6 to 12 weeks, depending on cause and extent of damage, or they may undergo surgery. So if you first contact, patient comes to you, they brought a patient to you, and possibly they have even gone to a medical doctor. But the person they saw was not able to identify because they misdiagnosis or they missed or misdiagnosis. This is a very sensitive case. We are not expecting that they will miss it. But let's assume it was missed and it comes to you and you're able to look at the image and you discover that there is instability or vertebral damage. You refer and you don't mobilize them for about 6 to 12 weeks until that damage is repaired or the instability is stabilized. That all is about prognosis. So very important, look at vertebral damage and instability. Another thing is the autonomic dysreflexia. So autonomic dysreflexia, I think I've explained part of this. Because I talked about the issue of motor nerves coming down at the same time nerves that supply their organs in the body also are coming down. It's the spinal cord. I've explained that. Another thing that I've explained is the issue of reflexes. So the reflexes, how you have the reflex arc, the stretch reflex, and what have you, and then you are having inhibition coming from the brain. So putting all those together, I think maybe it will help with the understanding of the autonomic dysreflexia. So you have exaggerated reflex response of the sympathetic nervous system to noxious stimuli. So when the patient's bladder is full, or when there is any noxious stimuli, maybe even the overpressure on the skin, especially the areas where they feel the stimuli. In patients with total or profound loss of supraspinal sympathetic control, mostly T6 and above are more vulnerable, occurs after spinal shock. So that's why I said we'll come to spinal shock. I think I've explained part of it. You have those reflexes below. This part of what I explained earlier. You have those reflexes below. When you have the injury, spinal cord injury, and at that point that you have inflammatory processes and other things that make those reflexes to go away. So the patient is in a spinal shock. When those things resolve, is it ischemic injury? Is it inflammatory processes? When they resolve, and then you now see the reflexes coming back. You say this person has gone off the spinal shock that they have had. So of course, usually this autonomic dysreflexia will occur after the spinal shock has resolved. Because whatever reason makes the spinal shock to be there, not to see the reflexes, will not allow this reflex, because this is also a reflex. It's an exaggerated reflex. Whatever stops the other reflexes that we see below that level of injury can also stop this autonomic dysreflexia from occurring. So the stimuli include blocked catheters. I was saying bladder distension. So blocked catheters, when the catheter is blocked, or when there is overdistension of the bladders or the bowels, when there are fractures or pressure ulcers. I mentioned pressure ulcer earlier. So all these stimuli can lead into that exaggerated reflex that is called autonomic dysreflexia. What are the symptoms? We'll see them. The stimuli excite neurons in the isolated sympathetic chain. I think it's important to go back and read about sympathetic and parasympathetic, but the bottom line is you have those nerves coming down. Some go to the motor system, some go to the organs of the body, and look at all those interrelations. You'll understand all this more. So without supraspinal control, to dampen the reflex sympathetic response, the sympathetic nervous system makes an exaggerated and unchecked reflex response. I've explained this, but with regards to motor. So now we are looking at a similar concept, but with regards to the organs of the body. So you don't have inhibition coming to stop them from. So what you are going to see is increase in blood pressure, headache. So widespread vasoconstriction below the level of the lesion with increase in blood pressure. So the blood pressure goes high. Headache, you have headache. Sweating, tachycardia, you have all those. So for the organs, this is what you see, increases. But for the motor, is the reflex, so that you see hypertonia, you see spasticity. All these are motor, because there is no inhibition coming on the motor side. But with this, there is no inhibition coming on the organs in the body. So you see blood pressure, you see headache, you see sweating, you see tachycardia. So systolic blood pressure of patients that have spinal cord injury is usually 90 to 110 millimeter mercury, usually, because of obvious reasons. The pump muscles are not contracting to be pumping, and therefore you find that it goes down 90 to 100. Whenever you have an increase to more than 20 millimeter mercury, it's indicative of autonomic dysreflexia. So what do you do? And that's what I was saying. When you see that, what do you do? Identify and remove the source of noxious stimuli. If it is a bed sore, you're changing in position so that that stimuli will reduce. Losing tight stockings and abdominal binders, lower legs and elevate head. So we're going to see with autonomic dysreflexia, we are lowering the bed, elevating the head, because the pressure is going high. When the pressure is going down, as we are going to see with hypotension, then you are going to do the opposite, and then avoid supine position. Then refer. And if they have been seen by a physician, the physician is going to give blood pressure relieving medications. Now, that's the next one, postural hypotension. So that also affects those C6, T6 and above. Loss of supraspinal control of the sympathetic nervous system and resulting in ability to control blood pressure, exacerbated by poor venous return. So that is, so when you have poor venous return in the lower limb paralysis, and loss of lower limb muscle pump, it leads into decrease. So postural hypertension when moving from lying to sitting. So that's the moving from lying to sitting, the blood pressure just goes down. So these are all explanations of why you have the hypotension, because the blood is pulled in the legs. So lie the patient down and raise the feet or tilt the wheelchair backwards at that time that they are having the hypotension. So with prolonged bed rest, don't mobilize them fast. Sitting in bed for a few days, sit out of bed with legs elevated. So these are some of the things that you do. Then bladder, bowel, and sexual function. Rely on coordinated activity between the sympathetic and parasympathetic nervous system and skeletal muscle control through S2 to S4 nerve roots. So when you have S2 to S4 nerve roots, you are going to have bladder, bowel, and sexual function. And these are things that we don't treat. We don't treat them. I see patients that really, they don't even tell you, especially the sexual function. And that is why we have a workshop that we're going to have. I can't remember what week, but in some weeks to come that we're going to have a workshop on this. So we're not going to deal a lot with this because we have a lot anyway on our plate for today, but there's going to be something like that just purposely for this. So injury below the cornus result in flaccid paralysis of skeletal, bowel, and sexual function. Yes, so these are just a few things looking at what is within our scope of practice and what is not within our scope of practice and how we deal with it. I don't know if there are any questions, because we are going to now go into assessments. We'll look at outcome measures. Any comment or question? Innocent, can you help put down your hand? Or maybe if the admin is there, please help put down the virtual hand of Innocent. Yes, thank you. Okay, any comment or question? Okay, so I'm going to go straight into the assessments. We have, okay, so are we going to talk about vertebral instability during assessment? Not really, because these are issues that are organic pathologies, and therefore they are more of assessing to know they are there, and when you find out they are there, you refer. So I'm going to focus more on what is within the scope of practice of the physiotherapist. As I've said, we are going to have classes soon on systems review, and then there we can have this as a case report. But we'll focus more on what we have identified that is within the scope of practice of the physiotherapist, and then we give assessment and treatment for that. Yes, but we'll have time to be able to do this in the class that we'll have on systems review. That is going to just be a practical class that will look at case reports just on systems review. Yes. So I'm going to begin to open assessment, but as I've said, I would like us to do this more interactively, and also I will show you how I get these outcome measures and how I get information about them, how I learn about how to use them, so that if we are not able to cover all of them, then you can be able to go away and be able to get to sort things out for those that don't need training, because there are many that don't need training. They are just straightforward. All you need to do is to get the information about them, and you'll be able to apply them, especially if you have some experience in the clinic. So let's start with the Asia, because that's the one that people have really interest in using, and there's a reason for that, because primarily that is where you are able to know what level of the injury that you have. When we come to look at management, we'll see the implication of the level to what the patient has and how you can build on what the patient has. So we're going to start with that. So for those that have not used it before, we're going to see it. For those that have used it before, we still go through it together. Okay, so this is it. The Asia, we call it International Standards for Neurological Classification of Spinal Cord Injury, but also American Spinal Injury Association. So that's why they call it Asia, because it was developed by the American Spinal Injury Association, but its name is International Standards for Neurological Classification of Spinal Cord Injury, ISNCSCI. So this is it. What I was asking earlier was to try to see how do you do the assessment? What assessments do you do? So if you look at this, it shows, remember the dermatomes. Someone mentioned dermatomes and myotomes, so at least summarized what you do. But let's look at it in more details. Now you have a patient. Why I don't have a patient here, would have done the practical, is because we did this. It's straightforward. I think I've explained it. We did it last week. We saw a video. I can still show the video again, but it's simple. You have a cotton wool when you are doing the sensory, because you have sensory, light touch. You can see the column where you enter light touch. And this is where you do the pinprick. And if you remember from that diagram that I showed earlier, there's light touch, which is more posteriorly together with proprioception. But then you have crude touch, which is anteriorly. So remember those locations and those positions. So now you are doing the practical. For light touch, you use a cotton wool. And these are the areas of those roots. So what we have here is for, I hope all this noise around me is not disturbing you. In the office, and just by the office, we have, I don't know, they're making a lot of noise. I just hope that it is not disrupting your attention. So you have the roots. Remember, I said for the dermatomes, you have roots representation in the dermatomes, but you also have peripheral nerve representation. So because we are talking of spinal cord injury, it is at the spinal level, the injury, not peripheral nerve. The presentation that we are going to use is that of the roots. And you can look at it here, you will see C2, C3, C4. And then you continue to see C5, C6, like that, T1, T2, and then for the thoracic, from T1 up to T12, then you now have for the lumbar L1, you have L2, you have L3, you have L4, L5, like that. So even the back, you are going to now have the sacral, S3, S2, S1, S1, S2, and then you have S3 around the sacral area. And then you also have S4 to 5. So these are the locations. Very important to remember that when you are with the patient, have the patient to lie down, you expose the areas that you are going to test. You use a cotton wool. You have to blindfold the patient, instruct them. When I touch you with this cotton wool, I want you to say yes. So that's just it, as simple as that. Close your eyes, blindfold them. When I touch you with this cotton wool, say yes. So if you want to test if there is sensation in situ, you touch this part of the patient's head, the posterior part around the occiput towards the back of the ear. The neck, you touch C3. And there's a particular point where possibly they feel more. The threshold is more. So this is C4. So you continue to do that. This C5, you touch the patient just below the shoulder, the arm, laterally. The forearm, laterally, C6. The forearm, medially, T1. Then you have just around the axilla band, but also the medial part of the arm, around the pectorals. You have T2. So you continue to do that. You touch, the patient says yes, you record. You touch, the patient says no. No sensation there. And that's how you continue to report. So you are reporting. For light touch, this is what you use. There you tick, is there, you tick, you tick, you tick, is there. And for pinprick, when you finish with the touch, using the cotton wool across these distributions, then you now come for pinprick. And for the pinprick, you know the pin that you have in your patella hammer, you remove, you touch the patient, and you don't drag, even with the cotton wool. Because some people will put it and drag. You don't drag. You just place it on the skin and you ask the patient. No, don't ask the patient when you place it, right from the beginning. Because when you say, do you feel it? The patient, of course, is going to say yes, even if they don't feel it. So just when I touch you, whenever you feel the touch, say yes. You can vary the timing for the touch. Because if you are touching the upper part where there is sensation and it's in a regular pattern, as you get to the part where there is no sensation, they will predict the pattern and they will continue to say yes. So you vary the pattern and you also vary the locations. So don't follow it C1, C2, C3, C4, C5 like that. You can vary it so that the patient does not predict the assessment. So when you finish, you have your score. So let's look at the scoring. So for each side, you give a score. So for sensory, this is the scoring. Let me enlarge if it's going to enlarge. Yes. So this is the scoring for sensory. So scoring 0, absent. So earlier I was saying tick, but you are going to give a score. You give a score of 0 if the patient does not feel the sensation at all. You give a score of 1 if the patient feels it, but not much, it's altered. Or when you do 3 times and they feel on 1 and they don't feel on the other 2, or they feel on 2, they don't feel on the third one. That also is altered. 2 is normal. No matter how many times you do it, they still feel it and they have normal threshold for the feeling for the sensation. Don't use 3 if you are not able to test. For example, the patient has amputation. So when you come to test that area, the hand is not even there. So it's not testable. Or the patient has bones in that area. Or the patient has bed sore in the area. Whatever it is that makes you not to be able to test, if you give a score of 3, someone will think that it is 3 that is a higher sensation than 2. And that is why they use NT. just not testable. So this is the scoring. So as you do C2, is it 1? Is it 2? Is it 0? You give the score. You go to 3. This is it. Was as you touch, you come here, you give the score. You go to C4. As you touch, you come here, you give the score. And that is how you finish light touch. You come and do pinprick. And this is for the right side. You now come here and you do for the left side. So it takes time. But if you are treating a patient with spinal cord injury and you don't do this, it will be really very difficult for you to be able to identify the level. And I will show you what that level means for your treatment. When we come back from break, that we're going to start management, I will show you that. And it's really interesting for me. And I believe it will be interesting for you. And therefore, it's important to take your time to identify what level that the patient has the injury. So when you finish sensory, you now want to do motor. For motor, it's only this selected, they call it key muscles. There are key muscles, there are non-key muscles. So the key muscles are the ones that you do. The non-key muscles, there are reasons that you will do the non-key muscles, but the key muscles are C5, elbow flexors. So this is your normal Oxford grading system. Elbow flexors, C5, wrist extensors, elbow extensors, finger flexors, finger abductors of the little finger. And then for the lower limb, hip flexors, knee extensors, ankle dorsiflexors, long toe extensors, ankle plantar flexors. So you enter the score. What is the scoring? This is the scoring for the motor. So the normal Oxford grading system. Total paralysis, no movement at all, not even a flicker, palpable or visible contraction, active movement, gravity eliminated, active movement against gravity, active movement against some resistance, active movement against full resistance. They now have 5-star, normal corrected for pain and disuse. NT, not testable like we did in cessation. So you put your scores, and I'm not going to go through discussing how you will assess elbow flexors. So your normal Oxford grading system. So when you do all those assessments, you now enter your score. So for sensory, it is 0, 1, or 2. But for motor, it is 0 to 5. 0 to 5. So you enter 5, 4, 2, 1, 0, whatever score that you have. And that is it. So you have finished your assessment. It's motor, it's sensory. You now, and you have right and left. So you now come down and you do your totals. So motor subscores. You have upper extremity right. So this is right, and this is left. Whatever scores you have for motor, you are going to total this 5 and this 5. So this 5 and this 5, you total them, and you have a total score, right totals for motor. Then you have total for your light touch and your pinprick. So light touch, pinprick for the right side. You also total the left side, pinprick, light touch, motor. So you see motor that has only 10 cells has 50, while this one that has almost 30 has 56. That is because for the scoring for motor is from 0 to 5, while the scoring for sensory is from 0 to 2 only. So that is why you have these scorings. So you have motor subscores. Upper extremity right, you have maximum of 25. Upper extremity left, you have 25. That is what gives you the 50. Then you have upper extremity motor total. For right side, you have, total for both sides. Because what you have is, now you are doing is this and this. So that is why you have 25 for right, 25 for left. You have a total of 50. And then you have lower extremity right, lower extremity left, 25, 25 each. You have 50. And then you have sensory subscores. Left, you have light touch, right, light touch, left. Then it gives you a total for the light touch. Then pinprick, right, pinprick, left, you have a total for the pinprick. So these are your scorings. You put them at that there. So let's not forget deep anal pressure. So you do deep anal pressure, that one comes with a yes or a no. You have voluntary anal contraction, that's a yes or a no. So these are also important to take note of. And then you are, so let's look at this, neurological levels. Steps 1 to 5 for classification as on reverse. So it is down here, the neurological levels, 1 to 5 steps in classification. So that's the classification. We are going to look at those classifications. But this is what is going to help in doing that. So number 1, sensory, right and left. So this is where you now come and understand what that is all about. So determine sensory levels for right and left sides. The sensory levels is the most caudal, intact dermaton for both pinprick and light touch sensation. So if you are asked, what is the sensory level? And you will have pinprick as C7. So you don't have pinprick as C7. So it's C6 that has both light touch and pinprick. That is going to be your sensory level, C6. So as you are doing this, if it's confusing, let me know so that I can explain more. I think it's important understanding this. That's why I'm taking time on it. So just let me know if I need to slow down, if I need to go back. But let me just ask, are we doing well? Is it okay? Should we go at this rate? Or do you want me to? Just a feedback will help. Because I would truly want people to go back and use this. Okay, it's confusing a bit. Yeah, I know. I know myself. It took me some time before I got to understand it. So very good. That's why I like the feedback. So it's very important that I go back. It is confusing. Thank you. Very good. Very good. Okay. So can you let me know what part is confusing so that I will go back to that part? If not, I'll just go back from the beginning because I really want people to continue to use it. That's why I asked earlier. And it was good that many people said they use it in the clinic. And so, but if it's confusing, let's go back and look at it more. Okay, I can't see any comments, so I'll just, okay, from the beginning, please. Okay, from the beginning. Okay, good. So if I make it smaller, I hope you can still see it. That's why I keep making it bigger and smaller. Okay, the sensory level part. Now, but do you have any problem with doing it practically? I mean, you need a cotton wool. You can even hold it. You can hold it as you touch the patient. You are now looking at the area. But with time, you will commit it to memory so that as you are just doing it, I told you about a tailor that I will go to that will measure the length of the shoulders, the length of the hand, the shirt he will measure everything, and then you will now go and pick his paper and begin to enter. And he does not forget. So some people can do that. You keep touching, and then at the end, you now sit down and you enter in your paper. But if at the beginning you can't do that, don't feel shy. Do C1, report C1. Do C2, report C2, like that. But what is important is that you know the locations. And for this, let's go back. This is C2. When you touch, this is the main point where you touch, but any other area you touch is okay. For the neck is C3, the shoulder is C4, and then lateral part of the forearm is C5. So you just touch that place with a cotton wool, and when the patient says yes. Now, another thing is because the scoring is 0, 1, and 2. When you touch and the patient says he has not felt it, he's just kept quiet. So you can tell the patient, even if you don't feel it very well, say yes, but say you don't feel it well. So maybe that's one of the things that we missed earlier, because it's 0, 1, and 2. Not felt at all, abnormal sensation, but it's felt, and normal sensation, it is felt. So your clinical judgment will help you to be able to understand whether it's there, but it's abnormal, or it is there, or it's normal. Very important, because those scorings are important. So C5, you give a score. C6, you give a score. T1, you give a score. You may not use that scoring to come up with the level, but what is important is that this is an outcome measure. If you have a total score, when you treat the sensation and it improves, later you are going to see an improvement from 0 to 1 or from 1 to 2. And that total score is important. But from what we are looking at, that may not really be what determine the level. So the scoring and the level of dermatomes. Okay, the scoring, wonderful, the scoring. That's okay, so mostly it's about the scoring. The deep anal pressure, how do you carry it out? Okay, we'll talk about that with pinprick or cotton wool. Across the boxes seems to be there for pinprick and light. Okay, so let's finish with the scorings. So as I've just explained, so the patient says, yes, I feel it. Spelling says, no, sure. Or you touch where the patient does not say he feels. You touch 3 times. And the patient says, yes in 1. He said no in the 2nd, no in the 3rd. Or yes in 1, yes in 2, no in the 3rd one. Then it's abnormal. When they have yes, 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 then it's full. It's complete. So that's C5. So because there's a lot to do, if the patient says yes, you move. But if it says no, then you want to do it 3 times. So that out of the 3, is off. If all the 3 are a no, they don't feel it, then it's a 0 automatically. So that's the scoring. So you give a score, and this is where you enter the score, 0, 1, 2, 0, 1, 2, 0, 1, 2, depending on which one you have. For light touch, you use the cotton wool. For pinprick, you use the pin. And this is for left when you are assessing the left side of the patient. And then this is for right when you're assessing the right side of the patient. So that's sensory. And the good thing is that you have C2, C3, C4 all across, but you also have C2, C3, C4 all across. So it's simple. Doing it, touch, report. And this is the scoring. Scoring on this side. Absent, altered, 2, normal. So that is for sensory. Then you have the motor. The motor, as simple as doing a muscle, Oxford muscle grading system. So elbow flexors, the patient's lying, resist, and see if they can move against little resistance or more resistance, or they can move just only against gravity. You give a scoring of 0 to 5, and that is what you enter in each of this. So it is possible that you do C2 and you report 2, C3 you report 2, C4 you report 2, but by the time you get to C5, you report 1, C6 you report 0. So what that means is that at C6 is where you don't have sensation. So you have for that light touch, you have C5. Then you now come and do the pinprick. You start C2, they feel, C3, they feel, C4, they feel. When they get to C5, they feel. When they get to C6, they feel it. Even if it is partial, you have 1. So what is your level? Because for light touch, you don't have 6, you have only 5. But for pinprick, you have 5, you have 6. Then your level is 5, because that is why you have 5 here, 5 here. You don't have 6 here, and therefore you will not take this 6 as your level. You will take 5 as your level. So I hope this makes it better, because that is what, under steps in classification, which is this neurological level. For sensory, what is the level? The level is, sensory level is the most caudal, intact dermatom for both pinprick and light touch sensation. So that is your sensory level. Your sensory level will be C5, as we discussed earlier. So you put your scorings here for sensory, for right and for left. And then you now take the lower one. So remember earlier we said we did for both pinprick and soft touch or light touch. So you put that lowest one as right. Then you put that for the left, so that you can have a neurological level at that level. Then motor. For motor, determine motor levels for right and left sides. So this one also, you do it for right and for left side. That is why you have this as sensory right and sensory left. So for both sides, you give the sensory level. So for motor, you do the same thing. Defined by the lowest key muscle function that has a grade of at least 3 on supine testing. So you don't need to have 4 or 5 to say that is where the level stops. Defined by the lowest key muscle function that has a grade of at least 3. Providing the key muscle functions represented by segments above that level are judged to be intact, graded as a 5. I will explain when I move on. Note, in regions where there is no myotome to test, the motor level is presumed to be the same as the sensory level. If testable, motor function above that level is also normal. So let's go back. We are trying to get the motor. So this is it. This is motor. Motor, 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 motor. You do this, and it says 5. You do this, it says 5. You do this, it says 4. You do this, it says 3. You do this, it says 2. So what is your level? Your level will be this. It's 3, and therefore the level is C8. So when you do elbow flexors, the score from 0 to 5, it gives you 5. When you do wrist extensors, it gives you 6. When you do elbow, 5, 5, because that's maximum. 5, it gives you 5 because they can lift against gravity and resistance. 5. Elbow extensors, it gives you 5. Or let's say 4. But when you go to finger flexors, it gives you a score of 3. But by the time you come to finger abductors, you get a score of 2. So the one that is 3, the lowest that has 3 is C8. Another scenario is that you can have 5, 5, 3, 3, 2. C8 will still be your level, because that is the one that has the last one with a 3, the most caudal, the most lower one that is with a 3. So C8 is your level for right. You do the same thing for the left. And that is what you put here. Sensory, right and left. So here you are putting the level. Is it C1, C2, C3, C4, or what have you in these boxes? So that's for sensory and motor. That's the neurological levels, 1 to 5. So let's now look at 3. Determine the neurological level of injury. So you have done sensory, you have done for motor. What they are talking about here in the non-key muscles, this is the non-key muscles. Because in thoracic, you are not going to do any Oxford grading system for T2, T3, because this is where the muscles, they supply muscles that are in the trunk. You are not assessing them. So what they are saying is that you have done sensory at this level where for the motor is non-key muscle. Whatever you have as sensory here, because we are talking of 1, if you have 0, then you go up to where it's 1 or 2. So if you have sensory, it stops at T7, 2 or 1, 2 or 1. You come here is 0. Your sensory level is going to be this level that you have 2 or 1 at the same level. So what they are saying is that since your Oxford grading system stops here, wherever your sensory is around this non-key muscle, you use the sensory as your motor level. So if your sensory level, you touch C5, the patient says yes, they feel it. Touch C6, they say yes, they feel it. But when you come to T7, when you touch, the patient says they don't feel it. So T6 is your sensory level. And since you are not testing any muscle myotom here, you use that T6 as your motor. It's your sensory, but it's also your motor. But when you come down to this level, you do your sensory. You have to now do this test for motor. So at the end, you come down here, you have your sensory for right, you have your sensory for left, you have your motor for right, you have your motor for left, and that is number 1 and number 2. So let's look at number 3. Determine the neurological level of injury. This refers to the muscular segment of the cord with intact sensation and anti-gravity 3 or more muscle function strength, provided that there is normal intact sensory and motor function rostrally, respectively. The NL1 is the most cephalad of the sensory and motor levels determined in steps 1 and 2. So simply, you are just doing sensory and motor so that you will see which one is the one that has all. It has the sensory, it has the motor. So meaning you can come here and you have sensory is at C7. But for motor, when you enter here, is at C8. And therefore, you are now going to take this one that has motor at C7, light touch at C7, pinprick at C7. So it has all of them across board. Anything that you have above in one column, you don't take that one that is below. You just take the one that is across board. So you have a 3 at C7, you have a 1 or a 2, a light touch, you have a 1 or a 2 at pinprick. So when you come down here is 0, 0. But this one still has 3. So you'll not take C8 as your level. You'll take C7 as your level. So that is the level. And believe me, when we come to look at that, we will show you a table that will show the significance of the level in what the patient can be able to perform. And that's why I'm taking time really to explain this. I hope it's better now. It might still be confusing, but I just hope that it is better at this point. So number 4 is determine whether the injury is complete or incomplete. Okay, wonderful. Thank you. Thank you so much. So this is now takes us to that question for voluntary anal. Remember, we looked at that sacral sparing. So that is what is going to show whether it is a complete or it's not complete. And that is where the voluntary anal contraction is. So this is something that you ask the patient or you observe. Can you contract as if you are going to hold yourself from defecating? So that's better now. Okay, wonderful. Thank you. So that is a yes or a no. So it's not scored. It's just a yes or a no. Then deep anal pressure. No, then injury is complete. So around the anal area is a pressure. You remember when we did a sensation last week? So around that anal area, of course, you'll have to use gloves and possibly then apply pressure and see if the pressure around the anal area. So when after that deep pressure, do they have any sensation there? Yes or no? So if you have a no, then injury is complete. Otherwise, it's incomplete. So if you have any voluntary anal contraction or you have deep pressure, then it's an incomplete. But if those two all have no to them, then it is a complete. So that also is important to know. That is number 4. So complete or incomplete. Incomplete, any sensory or motor function in S4 to 5. Asia impairment scale, okay, AIS. So that is 5. So 5 is now going to be this column, Asia impairment scale. A B, A, B, C, D, E. That is the Asia impairment scale. Number 5, Asia impairment scale. So you are putting A, B, C, and this is what Innocent, I think it's Innocent. I can't remember the name, but I think it was Innocent that explained this. Say A is complete. No sensory or motor function is preserved in the sacral segment. So if you do those tests that we discussed here, voluntary anal contraction, deep anal pressure, and they all say no, so just your Asia impairment scale is A. So it's A. But if it is not, it's a yes for those 2 items or one of them. Then you have either an option of B, C, or a D, or E. So, but what are B, C, D, and E? Sensory incomplete. Sensory but not motor function is preserved. So sensory is preserved, but motor function. So sensory but not motor function. Motor function is not preserved. Below the neurological level. So you have now identified a neurological level. I remember I was telling you, if you come to this level, for example, and you have C7 showing 3, because 3 is the maximum or minimum that if you have is acceptable. It doesn't have to be 4 or 5. You have 5, but when you come here is 3. When you come here is 2. So meaning 3 that is here shows that C7 is your motor level. But at the sensory, at this level you have 2, but here you have 0, 0. Even though you have 3 here, you are taking C6 as your neurological level. So what they are talking about is you have an incomplete, but you have a motor below what is acceptable as the neurological level. So let's go back there and see what they are saying about it. So sensory, but not motor function is preserved below the neurological level and includes the sacral segments. So you don't even need to mention the sacral segments in these ones because we have established if the sacral segments are spared, then it's not A. So it can be any of B, C, D, and what have you below. So what I explained earlier, I think is the reverse. So motor function is preserved below the neurological level, but okay, sensory is preserved, but not motor. So let me go back and explain that. So sensory is preserved, but not motor. So what that means is that when it comes to this level, sensory is preserved, meaning you have 5, 5, then you have 2 as C7. You have 2. But here you have 2, 2, 0. So meaning here you have a C6. How I wish I could write. It will have been better. But let me try. and so we have 3, 3, 2, or 5, 5. But at C7, you have 2. So at C7, you have 2. 2 here at C7. So here you have 2, 2. At C7, you have 2. So you still have 2 here. But when it comes to C8, you have 2. And then at T1, you have 0. So meaning at that C7 where you have 3 and you have 2, 2, C7 is your neurological level. But what this means is that below C7, you don't have motor. That means you have 2. But below C7, you still have 2 for sensory, and you have 2 for pinprick. meaning there is some sensory level that is preserved below the neurological level, which is C7. So if C7 is your neurological level, below it, you still have full score for sensory, but you don't have full score for motor. That is what that B is talking about. So meaning you have sparing of sensory below the neurological level, but you don't have sparing of motor below the neurological level. I hope and pray this has got to you. So sensory, but not motor function is preserved below the neurological level and includes the sacral segments. And no motor function is preserved more than 3 levels below the motor level on either side of the body. So let's look at motor incomplete. Motor function is preserved at the most caudal sacral segments for voluntary anal contraction, or the patient meets the criteria for sensory incomplete status. Sensory function preserved at the most caudal sacral segments, S4, S5 by LT, PP, or DAP, and has some sparing of motor function more than 3 levels below the ipsilateral motor level on either side of the body. This includes key or non-key muscles. It doesn't matter. Now, let's look at it from here, because that's what this is doing to simplify it. So determine Asia impairment scale as a grade. Is injury complete? If yes, you have AIS A, because you don't have the sacral sparing. You have your anal pressure and control not preserved. It's complete. So injury is complete? Yes, it's an A, straightforward, finished. If it is a no, is injury motor complete? That is what we looked at earlier. If yes, no voluntary anal contraction. So is injury motor complete? So it's motor complete, even at the no voluntary anal contraction, or motor function more than 3 levels below the motor level on a given side, if the patient has sensory incomplete classification. So they have sensory incomplete, no voluntary anal contraction or motor function more than 3 levels below the motor level. So it's confusing, really. And let me admit that at this point myself, I'm trying to struggle. But we are reaching towards the end, and let's sort it out together. So you have a yes for the AISB, and then if it's a no, at least half of or more of the key muscles below the neurological level of injury graded 3 or better. So if it's a no, it's an AISC. If it is a yes, it is an AISD. If sensation and motor function is normal in all segments, then it's an AISB. So at least we have reached up to 4. I think the issue is to sort out this, and just allow me to study it more, so that maybe after the break, I will give more clarifications on these levels that are below. But the one, apart from this part that we're keeping pending, is there any part that you want me to go through once more? Okay, wonderful. Thank you very much. Thanks. Wonderful. Thank you. Okay, so I think this is it, a very important one, but really needs a lot of study to understand it to that level that it can be applicable. What is very important, and that is clear, I believe, is what is the neurological level? That is at that 3. what is the neurological level? So we have both sensory and motor, and we take the one that is having everything. So if you go below that level, you have something missing. But at the level that you have both sensory and motor to the right and to the left, everything is intact at that level, is your neurological level. And that is important to take note of. And that neurological level is also always going to be either C2, C3, C4, C5. It is the level that is the neurological level. So having established that, when we come after the break, we are now going to see how that neurological level is important in establishing what the patient can do or what the patient cannot be able to do. Definitely, definitely, very important. If there is no SCI patient, even if you do it on a normal individual, you are not going to be able to know what neurological level the patient is at. Step 3 in the classification. Okay, let me see which one is level 3 in the classification. Okay. So level 3 in the steps in classification. Now that is the most important one. And what it's saying is that you have your sensory level to be 4, but you have your motor level to be 5. But for your motor level to be 5, it means there is nothing above that because motor starts from C5. And therefore, your neurological level will now be C4 because that is where you have light touch as full, as having sensation, and pinprick as having sensation. But let's go down below and make use of it. So you have C
I have my time. Yeah. Once that time don't reach, I don't leave.
Sorry, I had to change the Yes. Okay. I think I'm back. Okay. So as I was explaining, you do your motor and it gives you C5 as 5, C6 as 3, C7 as 3. C7, so C8 as C6, 3. The level that gives you your motor level. So your motor level C7. C7 as your motor level. You start with 2, 2, 2. But when you get 0, when you do your pinprick, when you get to C6, you have 0. Sorry, you have C7, where you have C6 is 3, C7 is 3, C8 is 2. Level. C7 is your motor level. When it comes to sensory, you have 2 as C5. 2 as C6. Here, you have 2 as C6, you have 0 as C7, meaning C6 as 2, you have pinprick as C6 as 2, meaning sensory is C6. So your sensory level is C6. 0. As C7 for pinprick, you have 0. That is why you have the maximum, which is 2 for both light touch and pinprick. But for motor, C3 is your motor level. So your general neurological level is going to be C6. C7 as motor, but the sensory level, because you have 0, 0. So therefore, you're the one that you have all the 3 at the same level, and that is C6. So C6 will be your neurological level. So you can have C7 your motor level, but if you have C6 as your sensory, because that is where you have C3 here, and you have C3 here, you have C3 here, it's common across neurological level. So that's the Asia, and very important, as I've said, on level. So knowing the neurological level, very important when we get to that management level. Other outcome measures, we have taken a lot of time on this, but I think it's worthwhile. Let's look at spasm, because from the explanation that I've made, if you don't have inhibitory impulses coming down, you are going to have spasticity and you have hypertonia. We can be able to assess if there is spasm. So very simply, you have what is called the Penn spasm frequency scale. Spasm frequency is from 0 to 4. You have no spasms, mild spasm induced by stimulation once per hour, and then spasms occurring more than once per hour, then spasms occurring more than 10 times per hour. And then the severity is just either mild, moderate, or severe. So if you know spasm, usually you see that in patients that have, say, neck pain, and because they guard their muscles to be able to feel the pain, you begin to see the spasm in the muscle. So you now, for the frequency, you score it from 0 to 4, and then for the severity, you score it from 1 to 3. So this is as simple as that, and that's why I started with that. This is called the Penn spasm frequency scale. Because of time, I would have, I didn't even share it. Okay, but I hope you heard what I said. Let me just quickly share. Yes, so this is the Penn spasm frequency scale. The spasm frequency is what you scale from 0 to 4. And then the spasm severity, you score it from 1 to 3. Frequency is, as I've said, I would have gone back to where I got it so that you'll be able to see more information about it. But let me go to another one. When I take 2 or 3, we can do that. So let's look at six-minute arm test. 6-minute arm test. But before we go to, I'm going to go to the website where I got it. So rehabilitation database measures. So I'm going to share that so that you will see how I get there. Okay, rehabilitation measures database. Yes, so just go to, this is what is called the Ability Lab. Many of those outcome measures, including the one that we just finished using, which is the ACR. So if you just go to search and you search, you are going to see international, the ACR is called international standards, just like I said earlier. So if you open it, it's going to show you the purpose. ACR impairment scale classifies motor and sensory impairment that results Click this. It's going to take you to what is free. It will give you a link to where you get it. This is the acronym ICR, as we have been calling it. The area of assessment, very important. What do you assess with the outcome measure? Functional mobility, strength, and upper extremity extremity. So, okay, because functional mobility. Assessment type is observer. Is the observer that assesses and put it in. What administration mode? Paper and pencil. You keep putting it down on that tool. Is there any cost to it? No, is it used? Spinal cord injury. So it's only for spinal cord injury. This is the key description. So we have already discussed it, we have explained it, but this is the key description if you wish to have that. Equipment needed, this is it. The time it takes from 10 to 60 minutes, depending on your experience using it for these ages. And then this is what is going to show the validity and reliability of the outcome measure, whether it's valid and reliable or not. All this information will show you all that. So that's just to show you where I got it and how I came to understand how to use it because of all those descriptions. So let's now look at so 6 minutes arm test, sorry, 6 minutes arm test. So go back to Ryan. Such, yes. Oh, come on. So test. This is cardiovascular fitness in individuals with spinal cord injury. So this is the tool. I'm going to share it just in a minute. Just want to show you how this information can be helpful. Assessment type, performance measure. So it's from the performance that you do the measurements. It's also free. The diagnosis is for spinal cord injury. And then you have the description. So this is the description. I'm going to show it to you later. What equipment do you need? Arm ergometer. So you need an arm ergometer. You need a heart rate monitor. You need the RPE scale. We are going to discuss. It's 6 minutes. And then whether it requires training or not, just reading an article and manual will be fine. And all this is about the psychometric properties of the outcome measure. So let me share the tool itself. So this is the 6 minute arm test. So the procedure, the heart rate measurements continually recorded throughout the study. So blood pressure should be measured before and after the test. So before the study commences, ask your subjects to empty their bladders because of that autonomic reflexia that we discussed earlier. So subjects are asked to complete a single 6-minute stage of submaximal exercise on a standard arm cycle ergometer. So they use the arm cycle ergometer to continue to cycle, and the power output will now be selected. The individual will show how to select the arm cycle ergometer. The aim is to attain a steady heart rate of 60% to 70% of age-predicted maximum heart rate, or a rating of 11 to 15 on the Borg RPE scale. We are going to have a workshop on how to do these assessments, so I'm not going to go into details of them, but this is for subjects that have tetraplegia. So you set the power output to 10 watts if the power wheelchair user is the person that you are using it for. So if you use, their grade is grade 4 or below at wrist extension. So when you do their wrist extension and they have grade 4 or below in the Oxford grading system, then you use a power output of 10 watts. But if the patient is using a manual wheelchair, then you use power output of 15. If the patient is a manual wheelchair user and they have grade 5 at the wrist extension and they are physically active, there is an outcome measure here for physical activity for people with disability. You use that and they are physically active, they use manual wheelchair and they have grade 5 at the wrist, then you use 20. If the patients are paraplegic, then it's either a female or a male. If it's a female that is inactive, you use 30. If it is a female that is active or a male that is inactive, you use 40. If you have competitive athlete or male active, if it's female but it's a competitive athlete or it's a male that is active, you use 50. And if it's a male that is a competitive athlete, you use 60. So what you do, whatever you have as a baseline for the patient, depending on these categories of whether they have tetraplegia or paraplegia and each of the categories that you have selected, an increase of 5 watts per minute, because it's 6 minutes. So for every minute you add by 5 watts, individuals with tetraplegia. But if they have paraplegia, you keep adding by 10 watts, keep increasing by 10 watts. The final steady state heart rate is averaged over the last 30 seconds because you keep taking the heart rate, you keep taking the heart rate. The heart rate over the last 30 seconds of the 6 minutes that the patient does this to get the results for the patient. So cardiorespiratory fitness in patients that have spinal cord injury. And this is how you record. You have the patient name, the date, you have the initial power output. So depending on whatever it is that you selected, on whether they are tetraplegic or they are paraplegic, you put in that, and then increase in power output for each minute. Is it 5 or is it 10? And then during the final 30 seconds, you average the heart rate, and that will be the score that you have for the patients. Remember, there's this assessment that you do earlier that I said we will do it in a later workshop. You also put the results there. So this is the 6-minute arm test, 6-minute arm test. And we said it assesses the cardiovascular fitness. So cardiovascular fitness in individuals that have spinal cord injury. Yes, so let's see if we can take another one before we go to break. There are many, but Asia took most of the time. But I think that's the one that is more difficult to understand. Others are very straightforward, very straightforward. So for spasticity, we have looked at the pain spasm, but modified Ashworth scale can be used. Tadeusz scale can also be used. We looked at modified Ashworth scale earlier. Now, another important thing for patients that have spinal cord injury is wheelchair skills test. So let's see, it's also straightforward, so I'm not going to stay long on it, but let me just share so that you'll see. Wheelchair skill test. So you assess their ability to use wheelchair. So the scoring is here. Pass, they do it safe. Fail, it's unsafe for them to use it. NP, no part, only for indicated skills. Testing error. So these are just the scorings. So what you have is rolls forward. So they can be able to roll forward for 10 meters. So you need to have this they have entered for a patient just to show an example. So you roll forward for 10 meter capacity of the and performance. Can they be able to do it? And while they are doing it, are they safe? So you tick for each of the two. So they can have the capacity, they can perform, but you see that they are not safe using it alone. These are the two things that you score. Rolls forward 10 meters in 30 seconds. So the first one, they may do it in 1 or 2 minutes. But if they can be able to do that 10 meters in 30 seconds, they have the score. Rolls backward 5 meters. So it asks them to roll backwards. turns 90 degrees while moving forward, turns. So they are self-explanatory. So you keep then ascension. So if you go to the site, maybe let's just quickly go there so that you'll be able to see the list of equipments that are required. These are things that if you have the full information, you can be able to get them for use in your clinics. So yes, so let's look at this. So wheelchair skills test. Yes, wheelchair skills test. So it's a comprehensive and generic instrument for the objective evaluation of manual wheelchair skills. So this is the link. What we just looked at will become, you can get it from here. Cost is free. Diagnosis, you can use it for brain injury, spinal cord injury, or even for stroke recovery, depending on whether there is need to use a wheelchair. So this is the description. Now this is what we are looking for, the equipment required. So you need obstacle course, you need patient's own wheelchair, hinged doorway, bench, 5 degrees and 10-degree incline, then 15 cm porthole, 2 cm threshold, 5 cm level change, 15 cm curb, and stairs. So you look for those things and you now use what we have just looked at. They are self-explanatory, and you can be able to now give the scoring for each item if you have this equipment. Let's see, there is grasp and release. So let me show the picture before I show you the outcome measure. And this, I just checked, it's not even up to $50, I think. It's something that you can be able to purchase. So this is the picture for the grasp and release tests. I'm going to show you what it is used for. It comes in a box, and these are some of the items. As I've said, it's not expensive. 48 or $46 was what I saw on the site when I was looking at how much it costs. So let's look at its description. I'm sorry, I know we need to go on break, but just give me a few minutes to round up. Yes. So we're looking at grasp and release test. So the grasp and release test assesses basic unilateral hand performance with manipulating objects with and without a neuroprosthesis in individuals with C5 and C6 tetraplegia. So the instrument is here. You just click, you are going to get it. It's performance measure, but it's not free. Remember, I told you it's not free. You'll buy, but it's not up to $50 to buy. Cost not known, but I've looked at it up. So it's for spinal cord injury. This is the key description of how to use it. We are going to go back to the tool, and these are the equipment required. So there's no need to even go through this because they sell them. They sell the equipment. When you get it, it comes with all these pieces of things that are in there. It takes a long time to assess, but it helps you to be able to know the level of function of the patient. Yes. So let's look at it. Grasp and release. Yes, so this is it. It's variant of, initially it was called pick and place test, but object test, structure and scoring methods are tailored to the tetraplegic population. So this is the procedure. Test begins, a pretest for each object is administered to familiarize the subject with the instructions for each test The patients are given at least 30 seconds for practice with each object. For all the objects, the sequences below are repeated as many times as possible in 30 seconds. For the block and peg, the objects is grasped in the starting area of the test. So what you do is to pick those objects from one point and place them in another point. That's basically what happens. But there are different types of objects, some that you grasp, some that you hold with 2 or 3 fingers, like that. So that's just a summary of how you use it. And then you have a scoring. So for the peg, when you pick it, for the weight, for the fork, for the block, for the can, for the tape, you use either they were successful or they failed. So you are going to do it more than once. So within 30 seconds, how many times is the patient able to do the activity? So if they do the first trial, they were successful, you score them under C. If they are not successful, you give a score under F. For the second trial, are they able to do it? Yes or no? The third trial, yes or no? There are 5 trials, and that is it. Then you get a total score for those, each of this. At the end, you'll have a total score for that. That's the grasp and release test. So some of the ones that I have there, we have. Now, let me just quickly show Braden scale for predicting risk of, because some of our patients may have the risk of having pressure sore risk. So let me just quickly show that. Yes. So you have the Braden scale for predicting pressure sore risk. You have the sensory perception, ability to respond meaningfully to pressure-related discomfort. So that the patient be able to respond to pressure-related discomfort. So unresponsive, does not moan, flinch, or grasp to painful stimuli due to diminished level of no consciousness or sedation. So either consciousness or sedation, or limited ability to feel pain over most of the body because of the lack of sensation. So you test that, it's either completely limited, very limited, slightly limited, or no impairment at all. Then moisture, constantly moist, because they can't be able to control urine, and possibly they are not always with something that will control. Yes. Then very moist, occasionally moist, rarely moist. So you give a score. Then activity, are they bed fast, confined to bed? Are they chair fast? Do they walk occasionally? Do they walk frequently? You give a score under activity. So that's the degree of physical activity. Then for mobility, ability to change and control body position. Then nutrition, usual food intake, whether it's very poor nutrition, probably inadequate, adequate, or excellent. And then you have friction and shear. So whether there is friction and shear. So potential problem, no apparent problem. You give a score for each. This is the date of assessment. You give a score for each, and you now have the total score. So that is the total score. The higher the score, I will show the higher, the lower the risk of them having a pressure sore. So if any of these items reads less than 4, then it means there is need to focus on that particular item so that the patient will be helped to prevent themselves from having any pressure sores. Yes, so let's look at something that is not impairment. Someone mentioned the spinal cord independence measure. Very important to look at that. So this is the SCIM. Someone said they use it. It's similar to Bartel index. Because for them, integration into their society is very important. And therefore, you look at not just the impairment, you also look at the activity and participation. So you look at the feeding, the bathing, the dressing, grooming, respiration and sphincter management. So respiration, sphincter management for the bowel and for the bladder, use of toilet. And at the end of the day, just like Bartel index, you are going to have a score of 0 to 100. And that shows you the level at which the patient is with activities of daily living. Okay, so someone is saying there is a revised version that is also available. That's wonderful. Yes, so there are many. In fact, in the folder, I have more than 30, and I'm going to send them all. But the reason why I'm even going to stop here is because I know I've shown you how you can be able to go to the site to be able to get the information about it. Very important to know what it is measuring. What is it measuring? That's one of the things that it shows. Is it measuring at the level of impairment, at the level of activity, at the level of participation? And at each level, what does it measure? Does it measure spasticity? Does it measure mobility? Does it measure functional activity? What exactly does it measure? Very, very important to take note of all those things. But the resources are there. You can look at more. And I'm going to send all these outcome measures, the ones that I have on my system, to you, and you can get more through that website that I have shown you. The moment you have spinal cord injury, you are going to see a list of many, and it's going to give you access to the outcome measure and also describes how it should be used, whether it is valid or reliable, and what equipment do you need. You can also go to websites and check the cost and availability, where you can get them. Over time, I think we need to have all these things in our clinics so that we can be able to use them to help our patients. Yes, so thank you so much. I know I've taken a lot of your time before the break. But is there any comment or question before we go on break? So chat, forum, or raise your hand. If there is none, then we'll go on break. I know we have gone distance without taking any deep breath. So maybe we'll go for break and we'll have an hour. That means we'll come back by 1:45. So by 1:45, we'll come back and then we'll start looking at management. Thank you so much. Well done.
재밌었는데.
What's up? You have 500. 500. What's the number? Okay.
Yeah, welcome back. I think we're going to go to the second session, looking at physiotherapy management. So let's look at the framework. I said when we return, I'm going to show you some of the important things why we need to know the level of affectation, either motor, sensory, or the neurological level. So we're going to look at that first. So let's look at this. These are the levels at which muscles receive sufficient innervation to enable reasonable movement. So if your level is C4, then you can be able to use the diaphragm. The patient can be able to use the diaphragm. And that means the patient doesn't need to be on support for breathing, and they can be able to breathe on their own. Anything above that, C3, and then they will need to have a support. And then if the level is C5, they can be able to use the shoulder, especially flexion of the shoulder and abduction of the shoulder. So shoulder flexion and shoulder abduction. And also the elbow, but only flexion at the elbow. So C6 is when they can have in addition. So whatever you have above, then, for example, in C6, it means the patient can still be able to do shoulder flexion and abduction. But in addition to what they can have for patients that have C5 level, they can also be able to add extension. So meaning they can have shoulder flexion, shoulder extension, shoulder abduction, shoulder adduction. And then in addition, at the wrist, they can be able to have extension at the wrist. So for C7, the patient can be able to extend the elbow. So apart from elbow flexion, they can now have elbow extension, wrist flexion, in addition to wrist extension that is available at the level of C6. So this is how you can be able to know what movements you can be able to have at what joints according to the level, motor level. So these are the levels all across until S2. Remember, at S2 is when we said you can have toe movement. And that's when we said when you have the sacral sparing, that you can be able to have toe movement and also anal control, because that's things that are supplied by those segments, that level. Now, another thing that is very, very important, having known the level and what movements you can be able to have at what joints. Another thing that is important is to look at activities of daily living and be able to know at what level, the neurological level, is it that you can be able to do those activities. So an example is unassisted ventilation. C1 to C3, the patient cannot be able to have unassisted ventilation. So they need assistance with ventilation at C1 to C3. So if the level of the patient is C1 to C3, then the patient has to be on ventilation for as long as possible. Then if it is C4, so it's going to be tetraplegia as C4, they don't need assisted ventilation. They can have unassisted ventilation. And for all other levels, the patient can have unassisted ventilation. So only C1 to C3 that they need assistance with ventilation. Then pushing manual wheelchair. For patients that are up to C4 and above, they can't be able to push manual wheelchair. So C4 and above. But if the patient has level of C5 to C6, injury at the level of C5 and C6, they can be able to push manual chair, but with limited ability. So they're not going to do it fully without support. So C5 to C6. But any patient that you assess the level and they are at level of C7 and below, they can be able to, so this can serve as the reasons to be able to decide on what to do for the patients. So even if a patient at C7 to C8 cannot be able to push manual wheelchair, it doesn't mean they can't be able to do that. It just means that they need training for them to be able to do that. And that is one of the goals of rehabilitation for patients with C7 to C8 and below. One of them will be to train them on how they can be able to push manual chair themselves, manual wheelchair themselves. So of course, at thoracic level or lumbar and sacral level, we know they can be able to do that. In fact, some of them may even be able to walk with interventions. Then how about hand-to-mouth activities? So can the patient be able to eat? Can they pick a cup of tea and take it to their mouth and drink? At the level of C1, C3, they can't. If the problem is at the level of C4, they can't. But from C5, they can be able to do that. They can be able to do that. So even if you ask them reach and drink, they can't, then you can train them. They should be able to reach to their mouth or do mouth activities or brush their teeth or drink or things like that. So they should be able to do hand-to-mouth activities. But they may need training to be able to do that, especially if they are at level of C5 or C6. Self-feeding. Well, sorry, with this, it's about reaching them out. But whether they will be able to manipulate things when they get to the mouth. So when I was saying brushing, I thought also that they can take the brush to the mouth, but they may not be able to manipulate it and do the actual brushing. So that is what you have that for hand to mouth. At the level of C4, they can be able to take the hand to the mouth. But with self-feeding, it will be limited at the level of C5. But at the level of C6, they should be able to eat, take food, take it to the mouth. Then for hand function, to manipulate things with the hand, even at the level of C6 to C7 and 8. So for example, you want to use objects that you manipulate with the hand. It's not just about taking it and picking it and taking it to the mouth. Maybe you want to open a bottle, you want to put a needle inside, a thread inside a needle, things like that. So you need to have hand function. There is what they call tenodesis. That is a type of surgery that can be able to help them to add to their ability to do things. So without that, it will still be limited even at the level of C6 or C7 to C8. But anything from thoracic and above, they can be able to have perfect manipulations of the hands. For driving, now with new technologies that people can be able to use to drive, at the level of C5, they should be able to use technologies to drive. Sorry, from C6, from the level of C6. So rolling in bed, even at the level of C5, they can do it with limited abilities. But from C6 and above, they can be able to do rolling easily. Horizontal transfer, we are going to see some of the examples of how they can be trained to be able to do rolling and horizontal transfers. But when a patient has level of C5, they should be able to roll, they should be able to do horizontal transfers, they should be able to do lying to sitting with limited ability at the level of C5, but at the level of C6 and above, they can do it very well. Flow to wheelchair with limited ability at the C6, C7 to C8. But thoracic and above, it's all right. Standing in parallel bars, they need to be at C7 to 8 to do that. We're also going to look at rehabilitation of patients that are at that level. So we're going to look at this level of horizontal transfer, rolling and lying to sitting. We're also going to look at flow to wheelchair, and then we'll also look at standing in parallel bars and walking. So we're going to all look at these rehabilitations. But at what level is it that you can train people to have motor learning for each of those activities? Is what this is showing. And you can agree with me that knowing the level, motor level or neurological level of the patient is very important in identifying at what level is it that you can be able to have patients do any of these activities. So these are just a few. We can be able to look at other activities and see, because the key in that is the earlier slide. To be able to do rolling, what muscles do you need? To be able to lift yourself up and transfer yourself onto another chair, you need your latissimus dorsi and your triceps. So let's see, latissimus dorsi does not show here, but the triceps should be there because we are talking of extension in the need for such activities. Now, we're talking of float wheelchair. We said you'll need your triceps, that is extension at the elbow, and you will need the latissimus dorsi. So let's trace and see at what point. Can you see limited at C7? So it can be done because you need C7 for you to be able to have extension at the elbow. Now, why it's limited is because it's not just the triceps that you need. You also need adduction, you need internal rotation. And that is something that can be provided beyond C7, up to C8 or possibly early at the first part of the thoracic region. And that is why you can be able to have this. So if you pick other activities, the first question is, what muscles do you need to be intact for you to be able to do those activities? Now, at what level can you have activities in those muscles? And that is what will determine at what point is it that you have limited ability, or that you'll have no problem with that activity, or that you are not going to be able to do those activities. So these are those just a few, but it's very important for you. That is what helps with prognosis. So this is like a prognostic thing. It helps you to be able to know what can the patient be able to do now. If they can't do it, they need training. But if, for example, a patient that has a problem in C1 to C3, meaning they can't be able to do hand to mouth, then don't train them to be able to do that. That is important to understand the concept of compensation and recovery. If the patient cannot be able to recover, right from the beginning, the prognosis will indicate. And therefore, you use compensatory mechanisms to be able to help the patient. But if the patient can recover, then focus on recovery. Strengthening, motor learning, very important. We are going to discuss these two issues, very important ones in the recovery of patients. Strengthening exercises and motor learning. So very important for the two. So remember, we said the level of injury will determine what type of intervention you give. So if the peripheral structures are affected, then what you need is strengthening and electrical stimulation. But even with this, a patient may have stayed without doing those activities for a long time. And they said, use it or lose it. So in as much as they have stayed for a very long time without doing those activities, either because they were not medically stable or because they have fear of moving, and then a therapist now comes to give them the confidence and train them, they may have lost the motor learning that they have had, and therefore you still need to include motor learning in the processes of treating them. But if right from the beginning, the injury or disease that they have, now the injury, since we are talking of spinal cord injury, is in the central nervous system and it's an upper motor neuron lesion, then you will need motor learning. What's more important is the motor learning, not the strengthening. But the other way around also happens. If you need facilitation of the central nervous system to send impulses, and for a very long time, the patient does not do the activities, then their motor units will reduce in the periphery, and that also will now require strengthening exercise or electrical stimulation to bring them back to speed. So these are the two concepts. What is the source? upper motor neuron or lower motor neuron. If you achieve one, you may lose the other. You still need to come and give it to the patient. So this is important. Now let's look at the strength training, because we are talking about muscles not getting the impulses that they need to move. So performance of motor tasks can be limited by the strength of paralyzed muscles, so or weakness of paralyzed muscles. So how much of strength do they have? So a patient with paraplegia due to injury in thoracic spine may be unable to transfer from floor to wheelchair because of complete paralysis of the lower limbs and poor strength in the upper limbs. But what part of the upper limbs is very, very important to be strengthened for the patient to be able to transfer from the floor and get up to the wheelchair? It is the triceps and the latissimus dorsi. So while the triceps extend the knee, because if you look at it, just try to lift yourself up while you are sitting. What you need is extension at the elbow. So you need the elbows to extend. So apart from extension at the elbow, if you are not able to bring your hands close to your body, meaning you go with abduction, then you are going to fall. So if you want to maintain that position, as you go up, your hands must be kept against your body. So if your adductors and internal rotators are not functioning well, then you are not going to be able to maintain that position. And for you to lift yourself and put yourself onto the chair from the floor, then you need to be able to maintain adduction and internal rotation, as well as extension at the elbow. So if you want the patient to be able to do that, and that's what I said earlier, it's very possible that you will identify from the level of motor level during your assessment using ACR. The motor level of the patient, say, is C7, and you think this patient should be able to do this activity. But remember, in Asia, what determines the motor level is C3. In as much as the patient has C3, then that is their motor. The lowest C3 that they have is their motor level. And if it is C3, then it is not full strength. And therefore, you need to build those muscles that are important for that particular activity. Now we are talking of lifting oneself from the floor to go onto a wheelchair. And you need to have extension at the elbow, and you need to have adduction and internal rotation at the shoulder. So those muscles that do that can be at 3, and the patient will still be determined as or identified as having a motor level of say C7, but it's 3. Since 3 is what determines what the motor level is, you need to now strengthen that from 3 to 4, from 4 to 5, before the patient is able to do that activity. So even if you say to the patient, can you lift yourself up, go onto the wheelchair? The patient tries, they can't do it. They can still be, they can still be able to do that. So their prognosis is that they can do that, but they will need strengthening of those muscles that were at 3 to go to 5 before the patient is able to do that. So very important to take note of that. The normal upper limb strength is not enough, even if it is normal, not to talk of the 3 that we were even discussing. Even if it is normal, because of the body weight, because of the lower limbs not supporting and helping. Because if you are trying to lift yourself from the floor to get onto the chair, you can use your lower limbs, contract them, reduce the weight, and then the hands will just complete the activities. But now you have someone that cannot be able to contribute with the lower limbs, and therefore they need more than normal strength in the upper limbs for the upper limbs to do all the activities that even the lower limb will support them to do. So you need to strengthen them, even beyond normal. So your 10 repetition maximum and what have you is going to now be a different thing from what you do in normal individuals. So normal upper limb strength, not enough. Increased strength above normal to lift entire body weight off the floor. Very important. Now, extended periods of deconditioning and overweight, because when they have spinal cord injury, they might become overweight because of lack of activities, and they eat, they are staying in one place. So it affects the level of strength required for compensatory use of the upper limb. So you need to consider that when you do strength training. For partial paralysis, strengthening the paralyzed muscle is required for functional tasks. So very important. As you do your motor level, you also know at that motor level, is it 5 or 3 that give you the indication for that motor level, then you need to strengthen them. Is it at 2? So there may be others that are below that level that are still weak, maybe at 2 or at 1. But the fact that they are not completely paralyzed means you can be able to strengthen them so that they pick more strength, and then that activity can perform easily. So a patient with C6 tetraplegia may have partial paralysis of pectoralis muscles, and you need the pectoralis muscles for adduction and other movement, and have limitation in shoulder horizontal adduction, so adduction, hence preventing rolling in bed. So if you have a patient at C6, you need to strengthen the pectoralis muscles so that the patient can be able to roll in bed. So you need to know what muscle to strengthen. Remember, I said it earlier, very important. We need to go back to our anatomy. What muscles do what? So I want the patient to roll in bed. They need the pectoralis muscle. What is the strength of the pectoralis muscle? It is 2 or 3. Then I need to strengthen it to go to 5 before the patient is able to roll in bed perfectly. A patient with incomplete paraplegia may have partial paralysis of tibialis anterior muscles and may be unable to hold ankle dorsiflexion during swing phase of gait. So this is a patient. In your assessment, they have paralysis of tibialis anterior, but you still want them to walk normally. You can strengthen it to the level that it can be able to maintain dorsiflexion. Then your patient should be able to walk. And therefore, focus on strengthening the tibialis anterior muscle. You need to do something specific. You need to do something specific. But if the problem with the tibialis anterior, then what do you do to improve motor learning? You now begin to include interventions such as motor imagery to begin to have some movement come back. And then we'll now begin to do interventions that will bring about motor learning. And we are going to look at those in videos. So let's look at the issues of strengthening. Now, this is a picture that is showing a patient trying to lift themselves from the floor up to the chair. So this is where their hands are on the chair, edge of the chair, and they need internal rotation for them to be able to achieve the task. So thoracic paraplegia, patients are often unable to perform this task because the insufficient strength in the triceps and latissimus dorsi. So strengthen them. And strengthen them, including all other muscles that will stabilize other parts of the upper limb while they are using this latissimus dorsi and triceps muscle to be able to do that particular activity. Something that we don't see much in our hospitals, in our clinics. With spinal cord injury, we are going to need them a lot, the suspension. Because if you have a patient that is in muscle Oxford grading system 2 level, then they will need to do a lot of activities in gravity counterbalanced before they are able to get to 3, where they can do movement against gravity. So very important for patients that have spinal cord injury. So strengthening exercises for the elbow flexor muscles using an overhead cage and slings. And for the knee, you can use it for the knee also to have this system at the knee so that you can be able to have flexion and extension at the knee. So when a patient has 2/5 or less strength, for the lower limb, you can be able to use a wood, a glass, or something that you can be able to apply something on it that one limb is under it. It is in between the two limbs so that the paralyzed and flexion in gravity counterbalance. The higher the tilt table, the more the resistance. And therefore, you can be able to adjust the tilt table for the patient to be able to do flexion and extension at the knee or the hip, the lower limb, while they are lying with the table tilted. So the more you tilt the table, the more the resistance. And therefore, you must start gradually push themselves off to strengthen the muscles of the lower limb, ankle, knee, and possibly the hip. Now, let's look at motor tasks. So we now see the importance of strengthening muscles. And for selectively strengthening the muscles, looking at the activity, what muscles are required for that activity? What is the motor level of the patient? So that we'll be able to know whether we can go for compensation or for recovery. If you can go for recovery, then go for strengthening of those muscles and go for training motor tasks. But if you cannot be able to strengthen them, because the motor level shows that anything below that motor level is gone, you need that muscle below the, whatever it is that you need to do. If it is feeding, the patient cannot be able to feed themselves. What you need to do is to get assistive devices that are going to help the patient with feeding, or they get someone help, a caregiver that is going to help them with feeding. Of neurological level shows that those muscles that have been identified to do that activity can be able to recover. Then you strengthen them. You give training motor tasks so that at the end of the day, they come back, they recover, and they begin to do that activity. Now, with training motor tasks, even after gaining for recovery or compensation, the brain may need to learn motor skills lost or that need to be acquired. So it's very possible that what the patient used to do before, because of the spinal cord injury, they have lost that. They now want to go into a different career. They were footballers. They used their lower limbs. They never had the skills to use their upper limbs to do dexterity activities that require dexterity. So meaning the brain has not acquired that skill to do those tasks. They were using the lower limbs. They are footballers. They can use their leg to do wonderful skills that mesmerize people. But they have now had complete spinal cord transaction. They are going to live their life on a wheelchair, but they now want to go into another career. They need to learn the motor tasks. So training motor tasks will be important for those also. But it can be that they can recover that skill for the lower limb. They can recover. But having been in bed for a long time has made them, if they could be able to juggle the ball 100 times, now they can only be able to do it 5 or 10 times. And therefore, they need to reacquire the skills that they have lost as they go back to be integrated into the community. So this is based on the concept of motor learning. And I think we have discussed the case of motor learning before. Oh, you can't hear me very well. Your voice is low. Feedback. Can you hear me well, or is it just this particular person that is sending?
I can hear you well.
Very well. Okay. So
Very
possibly the person that just sent me a message, please just check your system. Possibly is from you. Yes. Thank you. So this is the concept of motor learning. I'm not sure if in this series we looked at motor learning. There is what is called the explicit and implicit types of motor learning. That's what is called the procedural motor learning. There are a number of them. There are many different types. But I'm not going to go into details of that. But motor learning is about someone learning what they have lost, and it's a permanent thing. So there's what is called motor performance. If someone is taught, say, how to dribble a ball, and they're able to, they can do 5. They are not taught how to do it. They do it 20 times. But by tomorrow, when they come back and you say, can you do it? And they go back and do it 5 times, then they have not learned that skill. They have only performed it. So there's a difference between motor performance and motor learning. So when you go through the concept of motor learning, make sure that whatever the patient has learned as a skill, motor skill, that they are able to retain it going forward. They don't lose it. That is when it becomes motor learning. So identify needed tasks, considering limitations, recovery, and compensation. What are those tasks that can come back? What are the tasks that have been lost that you have to acquire new ones to be able to live life? So it's important for the therapist and the patient to sit down and discuss that and identify the task. What task will be dependent on what the patient needs going forward in life. So use explicit learning when there is no or little movement in an incomplete spinal cord injured patient. Remember, we discussed this with stroke. I said interventions such as neurotherapy, such as motor imagery are important at the point that the patient does not have movement. They help bring about the movement. And this is what is called explicit type of learning. So you use example motor imagery. So a patient that from their motor level, you know that they can be able to perform a particular activity. So you have the motor level, and below it, your assessment has shown they have maybe a flicker of movement, just a little movement. So that means that can be built. But at that point, you can't give them weight. You might not be able to do movement in gravity counterbalance. But then another thing is it even the muscles or the peripheral nerves? If it is the central nervous system that has been affected and they have just a flicker of movement, then motor imagery will be good for them before you now begin to teach motor tasks at a later time. That will see how you can be able to train the skills that will bring about motor learning. But at that early stage, you use motor imagery. You can use virtual reality. We have discussed all this when we discussed stroke last week. So very important if they have very little movement that you do this kind of interventions. And then proceed to task-oriented training. So the task-oriented training is what we're going to look at a later time. So now let's see how you train people to be able to have motor learning. A patient with C6 to move from lying to sitting. So they are lying. If you look at the way people sit, they roll a little bit and then they use their hand, they press and they go up. So we need to understand these movements in fractions. What is the first movement that the patient does? Everyone will have their different patterns of doing things. Some people will just go to sitting from lying directly like that. But many people will roll a little bit, then they will use their hands, and then they will support themselves and they will sit. So you can break that activity into bits, and then you teach the patient each of the bits before they now are able to combine the fragmented activities, and then they are able to do that activity as a whole. So a patient with C6 tetraplegia, unable to move from lying to sitting, may benefit from practicing a similar but simpler task as seen in this. So in this, they are trying to move from one point to another because there are activities that are required. If you break it down into pieces, you'll see that there are activities that are required to be able to move from lying to sitting. So there's also, remember I said, you roll to one side before you now begin to propel and use your hand to push and get into sitting. So you also teach the patient. So you can have the patient do this several times. And then you ask the patient to do this several times. Then at a later time, you now combine the 2 or 3 that were disjointed and they were done separately, and then you are able to now have that complete task done. So this is another task. A patient with C6 tetraplegia unable to transfer between a wheelchair and bed in this. So they may benefit from practicing a similar but simpler task that are seen here. So because so just let the patient lift up, go back. Now, this is not for strength. They may have the strength, but if the brain has forgotten, sorry, it's raining here. Let me just quickly close the window. Yes, so I hope you'll be able to hear me well. It's raining. So as I go through, just give me feedback if you can't hear me so that I can close all windows to reduce the sound of the rain. Yes, so remember, there are two things, as I mentioned earlier. There is the issue of strengthening the muscles to be stronger than 5 normal. But there's also the issue of learning. The muscles can be strong enough, but the brain may have forgotten how to do the activity. So this activity is not for strengthening. And therefore, the dosage you give is not for strengthening. It's for motor learning. They're clear enough over there. So wonderful. Thank you. So you are doing that. And remember, the number of repetitions for strengthening, 10 can do with a 70 or 80% of repetition maximum. You can give 30 repetitions, 10 or 20 repetitions, and you still strengthen the muscle. Doing motor learning that will help you with neuroplasticity. They said the definition of plasticity is the characteristics of an object, weak enough to yield, but strong enough not to yield all at once. So meaning you need many repetitions before you begin to have that synaptogenesis and dendritic arborization, dendritic arborization and synaptogenesis, and the two coming together to facilitate the pathway, and the brain will now begin to relearn what it has learned or learn new activities that it didn't even know how to do. So many repetitions, more than what you'll use for strengthening, will be required when you are doing motor learning. So this activity is for motor learning. It is not for strengthening. And your ability to identify whether the patient needs motor learning or they need strengthening or they need both, one coming after the other, is where clinical reasoning will come. And therefore, you need to look at your patient and see what do they need or which one do they need first. So this is another thing. When you want to transfer, when you lift yourself, you go forward. And therefore, you teach the patient 2 benches at the side, lift and then go forward, then go back. Lift, go forward, then go back. Then after that, you now teach the patient the next task. And as I've said, you now combine them. So this is a procedural type of learning. And it helps in patients that have spinal cord injury to be able to learn them in bits because they can't be able to combine them at the early stages. So this is another one. We want to transfer horizontally, but it's difficult. So you can be able to, from the initial, you can be able to have this after doing those other ones that we have looked at. So a patient with C6 tetraplegia learning to shift and bear weight. So these are also motor learning activities. You want to bear weight on this upper limb because as you are in this position, there are many activities that you can be able to do. But if you can't bear weight on this and manipulate things with the upper one, then it will be very difficult to interact with the environment. So you want to reach out and collect something while you're in this position. You need to be able to bear weight here and also be able to have this independently do things. So this is one of the things that they will do, place a little ball on the shoulder and say, okay, try to stabilize it. As you are doing that, you'll bear weight here and you'll be able to now use this upper limb. So the brain is learning all those activities, although it's much better to use a task that the patient needs, even in doing tasks like this. Very important. So this is another activity. A pair of bathroom scales can be placed, of course, so that you'll be able to see how much, as feedback, how much pressure is the patient using to do the activity, and then you can continue to improve as the brain training. We have looked at task or generally trying to learn new skills using either motor. These are things that we learned in stroke, but they are also applicable here in spinal cord injury, especially because researchers, I'm going to show you one of the research that has shown that in the past they thought neuroplasticity will take place only in the brain. But now researchers have shown you can have neuroplasticity taking place even in the spinal cord. So balance is required to maintain center of mass within the base of support while carrying out functional tasks. So with patients that have spinal cord injury, can render the postural adjustments needed during functional tasks impossible due to paralysis. And therefore, you need to train them to gain balance. So you see our patients need to learn to use different postural adjustments. Remember, we discussed the issue of the visual system, the proprioceptive system, the vestibular system, all contributing towards having postural adjustments. So when someone has spinal cord injury, they may lose the proprioceptive input for postural adjustments. And therefore, the patient needs to either use vestibular or visual at initial stages. But that of the proprioception, unless if the information to the proprioceptors are completely cut off, if it is incomplete, it's partial, then you can be able to now have exercises that will help to facilitate the passage of information up. Now, it's not top to bottom, it is bottom now to top. But the more you do the task, the more the impulses are being sent. If they don't connect, at some point you'll have the dendritic arborization, and then you have the synapse formed, and that way you facilitate the passage of information. So you can still have that in spinal cord injury, even though you may not have what we call the synaptogenesis because it's in the spinal cord, not in the brain. But even in the spinal cord, you have the cells. Remember earlier, we looked at the gray matter where you have cells. And in as much as you have cells and information goes to that cell, it does not connect. It can now have a dendrite that will connect to a redundant cell. So that's neuroplasticity. So for balance too, you can be able to have that, but now it is not with motor nerves. It is now with the sensory ones that are picking information about proprioception, taking it up, that can now be facilitated using neuroplasticity. So balance should be developed within the context of the functional task. So if you want to train patients' balance, you train patients' balance according to the task that they need. So this is an example. So a patient would want to reach out to pick a bottle, and they don't have good balance. So when you are training balance, train the balance while doing those activities that are important for the patient. So there are T4 paraplegia, having difficulty maintaining an upright position while repositioning the hands during transfers, may benefit from practicing repositioning the hands in a similar but simpler task while sitting on the edge of a plinth. So they are reaching as if they are going to fall. You give them feedback. Don't fall. You are moving towards this side. Hold your body. Don't shift your hip, because if you do that, you widen the base of support. So initially you can do that, but over time, you begin now to maintain the position of the hip to improve the balance of the patient. So that is that. Now, ambulation. And this is where I'm going to use some links to be able to see some videos that will help us to understand these things. The first one, use of back slab and working frame, is something that is very, very common. I just put the link there, but I'm not going to show it because many of us do that. Now, there are some other gadgets that are now being used. Now, you might say, we don't have them here. Why do we need to study them? But when I look at them, I see the potentials that we can work with engineers to be able to come up with something that is less expensive, but it has the concept in it. And another thing is, we treat many patients with different sociocultural and economic backgrounds. So it's very possible you have someone that is very rich, you are treating them, and they can be able to afford this. If you understand how to use it, then you can be able to recommend for them to be able to buy them. Whichever way, knowledge that has been shown to be good and effective and impactful to patients, we should study it with the view on how do we get acquainted with it to be able to help our patients, either modifying it to make it cheaper or using that exact one to those that can be able to afford it. So I think even though we don't have them, I would still go ahead and show them. So as I've said, number one is back slab and working frame for ambulation. I'm not going to use that, but let me start with exoskeleton, and I will explain how it works. This is still looking at what we have been discussing on training motor tasks. So it's still on training motor tasks. So I don't know if you have any comment, feedback, question, just feel free to ask while I'm sharing.
The exoskeleton is designed to help you stand, balance, and walk through repetitive motion. The exo can benefit you if you have had a stroke, experiencing lower extremity weakness, paralysis, or other neurologic or neurodegenerative outer framework you wear. Using a computerized controller, the therapist sets walking parameters based on your needs. Motors enable you to stand and walk on level surfaces. The system activates the first step. Then you initiate steps through muscle activation and/or weight shift. As you balance and take a step, the exo determines the amount of assistance needed based on muscle activation and adjusts accordingly. Exo promotes both weight-bearing and balance improvement. With the therapist's help, you learn to correctly balance and weight shift when wearing the equipment, so the proper walking pattern can be rehearsed and relearned. This reciprocal stepping and repetitive pattern retrains the brain. The exo has also been shown to aid in improving bone density and increasing core stability and circulation.
Okay. So wonderful. I have seen questions. I'm going to answer them, but let's go through some of these videos and then I'll come back and answer. Yes, but were you able to hear the voice? Were you able to hear the voice? Because the other time we played the video, you couldn't hear the audio. Was the audio
Yes,
there?
sir.
Okay, it was there. Okay, wonderful.
Audio
Okay,
was-
so let's just discuss
Yes, it was there.
that. Okay, wonderful. What do you get from this? What do you think of this technology of ambulation in patients that have spinal cord injury? You can speak to it or post anyone. What do you think of the technology? So that's why I left it as an open-ended question. Just anything, what are your thoughts about it? Can a patient with poor trunk control use this device? Yes, because that's what they said, that it can help learning the mobility, the task, the walking task, but also it helps with trunk control. So that's why you see the exoskeleton comes up, even up to the trunk. And it is connected to the lower limb. And it's like a robot. It is going to sense where you have movement, allows you to move. Then it will sense where you don't have movement, and it will assist with the movement. But what is most important is that the patient makes an effort to do the movement. If you make an effort to make the movement, that is when you facilitate the pathways. If you don't make an effort to do the movement, it's just like a passive movement, the brain will not learn anything. So this is one of the important things to take note. And before they use that exoskeleton, maybe in one of the videos, you'll see how they took measurements. So for patients, they will took measurements. Do they have dorsiflexion? Okay, if they don't have dorsiflexion, how do they make the exoskeleton in such a way that it is going to give assistance, but not complete movement for dorsiflexion? What other movement is it that the patient does not have? Of course, they can take a statistics to say that amongst patients, many patients, these are the areas that they need support from the exoskeleton. We know that in many patients, they will have problem with dorsiflexion, tibialis anterior. They are going to have a problem possibly with maintaining abduction when they move. They are going to have a problem with bending forward when they move. They are going to have a problem with flexing the hip and knee. So these are the things that they will take. Then they will now look at each joint of the exoskeleton. How do they make it in such a way that it supports, but without giving complete a movement to the patient? And then the patient can be able to use it, support themselves, but they are able to do the movement, and the brain continues to learn the movement until the point that they even don't need the exoskeleton. They will now be able to move on their own. How do we train independent movement to prevent total reliance? And this is what I've been explaining, that the effort by the patient is what stops the reliance. If the patient does not make any effort, if you look at the video again, you'll see that there is effort from the patient. And that effort is what the brain is learning. And the more the brain learns from the effort of the patient, then the exoskeleton is not going to serve as a liability. But when the patient does not make any effort and the machine is the one that does it, and the machine is made in such a way that it is not going to give you full movement. It's not going to give you the movement. It's just supporting you in areas that if it doesn't support it, it's just like the back slab that you use. For back slab, it does not allow you to use your knee. And that is one of the limitations. If you don't flex the knee, the brain will not learn movement with knee flexed. But if you look at this machine, it supports the knee so that you don't fall. But at the same time, it allows the knee to be bent. You are bending the knee, but it is now sensing the movement and locking it. When it locks it, but it allows some movement to occur. And that was why it's expensive, because it's going to do two things: support, but still allow movement at the same time. And that is what helps the brain to learn, and so that the individual is not going to depend on the machine. Okay, yes, I think you say that's what you're explaining. Can a patient make use of the exo in the absence of the PT? Yes, I'm going to show you another video where someone even was going to a market to buy things alone, just using the exo. How do we train independent movement? Okay, I've answered this. It is a very welcome innovation, and I also look forward to the days we will be able to improvise a cheaper prototype for our local patients. When I came back from Southampton, I think I mentioned it here in one of the workshops. I can't remember, or maybe it wasn't here. One of my, in fact, the person that examined my master's in Southampton, her name is Professor Jane Borich. If you Google her, you'll see many of her studies using robotic therapy, the one that I showed you when we did stroke, robotic therapy. The company that developed the machine gave her one of the machines to do research. And one of my PhD colleagues, that time I was doing my PhD, he was the one using it. So he did a workshop, we went and we all tested it. We saw how interesting it was. Watching when they use someone and the person will move. You find out that the robot supports you where you can't move, allows you to move. I now thought, how can we have something like that? Department of Mechatronics, and I spoke to a colleague there. Because that time I didn't even know that mechatronics was there. So the mechanical engineer told me that it is best to meet with mechatronics. Brought in someone from physics. We brought in a number of professionals from different fields, biomedical engineering and what have you. And about 10 of us sat down and we now began to discuss, how do we come up with something that will be simple and cost less? It may not give us what the robot will give us, but it will give us something better than what we do. And we came up with something. We even applied for funding. But unfortunately, my activities and association administration did not allow me really to move forward. But I still have interest in pursuing. Now, just yesterday, I had a meeting with a team in South Africa and Netherlands. There's someone that's doing a program. I don't want to mention so that we will not be able to know who the person is. They may not want it to be public. But we are working on coming up with another technology. So, I mean, it's just about putting in the effort. We don't lack ideas, but we just need to make the effort. And we need to stop thinking that things are not possible here until we go wait for people from outside to do it, and then they send to us. Usually they will do it within the context of their own culture and other things. So we need to really open up our mind and start to develop these things. And that is why I'm showing us all this, even though I know they are too expensive, may not be available here. So that's a response to that comment by Ajayi Taiwo. What is the cost implication for the exoskeleton? You can Google it. It's very expensive, but I know it still will be affordable to some very rich people that you might be treating. If I treated a patient who went out of the country and they used it on them. They didn't buy to come back, but it was used on the patient. At some point, the patient came back, and we continued training using our own ways here. So it's okay. Let me go down. Can it be useful in an uneven floor / ground? Yes, it can be useful. It can be useful because it doesn't stop you from manipulating and obstacles. All it does is just to support you where you can't be able to move. So the trunk will go forward. It will hold the trunk. The hip will go with adduction. It will maintain it in a neutral position so that if it goes into adduction, one foot will drag against another foot. So it will open up and make sure, and then your foot will go into plantar flexion. It will maintain it in a neutral position so that you can be able to now have the dorsiflexion that you need without having the plantar flexors to drag the foot. So these are the things that the exoskeleton does. It's not that it restricts you from doing things. It gives you support while you are trying to do those things. I also like the fact that over time training will develop dependency in patients and not total independence on the device. Exactly. That's another interesting thing. So thank you so much, everyone. I think there are some questions that are related to what we did earlier. I will come back to those after we look at some more videos. Yes, so let me see what other videos that we can get. Yes. Okay, so carbon fiber. Okay, let's just see this one. Maybe just one more on exoskeleton before we go to another thing. Someone asked if you can be able to use it without a therapist. Okay, so this is how they did measurements to develop the exoskeleton itself. The good thing is that I think it's just 1 minute 30 seconds. So carbon fiber reinforced exoskeleton, that is the CFRP. So this is how it's made. There's no audio, I think. I can't hear it myself, so don't worry. I think there are text and the pictures. It's not Muhammad, I will answer that. Okay, so Usman was asking if we can't use it if the patient has a power of 0. Remember, you hardly have all muscles when you have a spinal cord injury having the same power. So you'll have some that have a good power, some moderate, some low. So that is the concept, and therefore you can have some that are at a level of 0, but others are not. Therefore, you can still be able to use it. So, of course, if you have a very high level, to say it is at the cervical region, so you can't be able to have even movement in the upper limb to be able to support what the things that you are going to do with the lower limb. So the same thing with the lower limb. If you don't have any movement in any of the muscles, then what effort are you going to make? So we'll now come to look at functional electrical stimulation with, say, bicycle ergometer. There is something like that, where you don't have the movement, and as the electrical stimulation brings the movement and you are cycling, and then you are able to have motor learning, even without a lot of strength in the muscles. But when you don't have movement at all, remember earlier I said use motor imagery. If it's 0, and the 0 is not just in one muscle, it's the muscles across board in the lower limbs. Use motor imagery. Use whatever it is, virtual reality, whatever it is that will bring about movement. But when you begin to have movement, then you can now go to functional electrical stimulation and bicycle ergometer. And after that, you can now come to the exoskeleton. So you don't just go to the exoskeleton straight away. The amount of strength that you have across a number of muscles will determine which of them that you use. So I'm going to show you another one with functional electrical stimulation and bicycle ergometer. I'm going to show you another one with suspension, weight bearing, and treadmill. So all these are applications, and they are all alternatives. But at some point, they may not be alternatives. They may be that one comes at a particular point and then one follows, like we did with the motor imagery coming first, and then others coming later. So let's see if there is another one that will be important. Yes, so let's see gait orthosis. Maybe that's the one that will show the patient doing it themselves. I don't want to take a long time with this, but it may not go up to the end of the video, then we'll go to the next one. Yes, I believe this should be the one where the patient, but it's long, so we can skip just to show relevant areas before we go to the next ones. So while it's, and this is getting hot.
Fourteen years ago, I was in a snowboarding accident where I fractured my spine due to a bad landing off a jump. Introduced to me during my physical therapy session. The doctor had asked me if I wanted to try it. I really wanted to walk using my own legs since they were still there. There was a chance for me to walk again, and I didn't care how I looked. I just wanted to walk on my own. I've gotten this far today because Dr. Kawashima from the Physical Therapy Research Facility has provided his expertise. The gait orthos.
Yes, so I think we don't need to go far. The videos will be available on the slides so that you can look at them. But that's just for someone that asked whether the patient can use it without a physical therapist. When you go towards the end, possibly you will see someone walking around in a superstore trying to buy things while using the exoskeleton. Now, if you look at it from earlier, you see the materials. It's not really too much of machine and computers. And therefore, it's something that I believe if we understand the concept very well and work with engineers, we should be able to come up with something that will help patients and it will be cheap. So let's see what's next. So we are done with exoskeletons. Now, mobile suspension system with ambulation. Mobile suspension system. There are also different types of mobile suspension system. I will just try to pick a few.
Or decrease the height of the machine, depending on how tall the patient is. So here you have the harness. So strap the patient. You want to place the harness so the buckle is face outward and the strap is auto. Lowest horizontal strap should be level with the patient's greater shoulder. And you want to make sure that the strap goes between the patient's legs and hooks to the front of the harness. All strapped in. Now the V strap has to come under the patient's legs and hook to the very front. Once she's clipped in, don't forget to tighten the strap. And you want to double check these straps to make sure nothing is pinching. Now it's time to tighten all the other straps. You want to make sure to do a quick check again before having the patient hooked up to the body weight supported treadmill and before you have the patient start again.
So the service provider again. So this is using treadmill. And when you have the straps, then there is a suspension. The computer that could give automatic suspension so that depending on the weight of the patient, it provides different suspension for different patients so that it supports them and to walk. Even if they are just making effort to lift the foot and put it there without their weight, the brain is learning how the movement takes place. So you're going to see something like that here on down here. I don't know if the network does not allow us, maybe I'll just explain and we proceed as happening with the network. Okay, so if you're lucky, okay.
Hey everyone, this is a presentation on how to use a body weight supported treadmill. And once she's clipped in, don't forget to tighten the other straps.
Okay, so let me use the other browser. It seems okay. The server's coming back.
It's a body weight supported treadmill. And this is at the clinic called
Okay.
to make sure to do a quick check again before having the patient hooked up to the body weight support treadmill and before you have the patient start again. Hook onto the straps light gate. The straps on the light gate can be tightened or loosened based on the patient's height. Straps of various tensions can be hooked onto the harness to provide. Now the V strap has to come under the patient's legs. Once the patient is strapped in, walking on the treadmill can begin. Once she's clipped in, don't forget to tighten PTs. Can also facilitate specific strap and make sure. In this case, now it's time to tighten facilitator's right leg. Check again before having the patient hooked up to the.
Okay, I think, I'm so sorry. Two devices working at the same time. Very confusion.
Sure. So other lower extremity. The light gate can also be out the cover. Two PTs help facilitate lower extremity movements, or one PT takes them one each. There's also additional equipment if desired to analyze the patient's gait pattern. This machine illustrates step length, stride length, basic support distance, or stance time patient is productive.
Yes, okay. So this is the body weight treadmill, a supported treadmill. So mobile suspension, I think there's the other ones I have. So I don't think I need to. So what's happening? First, electrical stimulation.
Hi, I'm Beth, and I am on the FES 200, a functional electric stimulation machine. It is a recumbent helpful for me. I'm a paraplegic from the waist down, and this is a great machine for me because it moves my legs for me, or actually helps me move my legs, I should say. But it also gives me an upper body workout as I'm moving my arms as well. It is absolutely terrific. It gives me a lot of information on the screen. It helps me make sure that I am keeping equal pressure with both legs and how much stimulation I'm getting. And it's really, really helpful. I have been using the machine for quite a while now. And I really enjoy.
Beth allows for patients to use simultaneously the arm Now, Beth is currently only using the leg stim as she has up. This device we can set up for the shoulder, we can set up for the back. It just allows for more encompassing and a more full body workout. You could use it for muscle muscle training, but also you can use it for cardiovascular conditioning. Beth has given some feedback in regards to symmetry of the device from her right to the left side, as she does have some asymmetry. It also provides her with some feedback in regards to her overall speed and the power output in which she's given. As a therapist, you're allowed to modify parameters, and you can kind of continually challenge patients by adding. Here at the hospital, we also use it as part of
how I know someone on the issues of virtual reality. What you saw there, monitor that the patient, the screen will show while the patient has to follow suit and do similar to what the patient in the screen is doing. And for that virtual reality, they said it's a simple thing. They said of movements and body activities you need. We'll be able to put them onto the computer screen, and then you can be able to a system, whatever it is it treadmill, is it just and imitating it and things like that. So have in the country with the right effort and collaborations. So that's that. Let me see what next. So we're not going to look at any more exoskeletons. Well, supported treadmill. So I think treadmill with body weight support, we have looked at that. The last one before we now begin to look at articles. So we're going to look at articles with some interventions that we have seen. So let's just look at the last one.
And are looking to apply for U.S. permanent residency, then discussing an exciting option.
Training is a valuable form of therapy for neurorehabilitation, enabling functional environment. The next step on Wang's system is that provides a rehabilitation environment that's open and accessible. When training with a treadmill, the single point suspension of the next step on Wang's system permits functional versatility. Partner with the Biodex Gait Trainer 3 and take body weight supported treadmill training to the next level. The Gait Trainer 3 merges audio cueing, visual biofeedback, and music-assisted therapy component to revolutionize the treatment of. The Gait Trainer's exclusive instrumented deck provides objective reporting required to prove need, progress, and outcome. While the next step on Wang's system delivers the added assistance to help patients regain their confidence, their strength, and their stride. Training allows every patient the opportunity to get an early start on rehabilitation.
Lifters, very, very expensive, but some people just thought of a local mechanism, and they use this. You'll see a jack lifting a tractor, and you'll be surprised, this little thing lifting a tractor. There's nothing they can lift. So if we use those kind of mechanisms, then we can be, that's why I shot this video, because apart from the treadmill, you'll see them use something that's very simple. It just has something that holds onto the patient. So if you put in something, a mechanism like the jack, where it's just manually that you lift it and it lifts the patient, you find out that you can be able to use that mechanism. So let me share some of the articles that I've got. And I know many of us have attended the workshop on evidence-based practice. And therefore, it will be easy to look at those articles. When we go back, we can be able to search and extract information from articles that we can be able to use for our patients. So let me just show an article that showed that neuroplasticity can take place even in spinal cord injured. So that's it. This is it. So exercise-induced signaling pathways involved in motor recovery after spinal cord injury. So this review describes the non-molecular effects of exercise and how they alter the CNS to pacify the injury environment, increase neuronal survival and regeneration, restore normal neural excitability, create new functional circuits, and ultimately improve motor function following spinal cord injury. So you can achieve a lot injury. So I'm going to send this article. You can see the pictures that show the reconnections that you can have. Here you have only 2 connections, but here increase in the number of connections will lead into increase in learning and the motor learning. So there's a lot to learn from that. New studies showing new mechanisms of how we can be able to help patients using exercise and other motor learning interventions. I've opened many things, so it's taking a while to open. Okay. So this is another interesting one. Repetitive transcranial magnetic stimulation or recovery in lower limb muscle strength and gait function following spinal cord injury. These are randomized control trials. So the objective was to investigate the effects of this RTMS, that's what they call it. So compared to sham stimulation on the development of lower limb muscle strength, gait function in spinal cord injured patients. I said that RTMS may increase long-term training, induce recovery of lower limb muscle strength following SCI. So very important that it has shown that it can be effective in doing that. So another thing that's important when you look at papers like this is to look at, give us the links so that we can go through them. Yes, sure, I will send the links. I will send all the links. Unless if you are saying that we should stop here. I know people are tired, and it's okay because from morning till now, putting in all this information, it's enough to make people to begin to lose the message. So what I wanted to do was to just show where you will go to pick information about how to use the intervention, because that's what I thought last week. Instead of giving the information directly, let's just learn how to get the paper ourselves, go into the paper and be able to pick the information. So as I was saying, one of the important things is to look at the participants So who are the participants? What is their characteristics? So this is where you look at the participants. You see the ASHA impairment scale, and you see information about them. Then, if you want, these are outcome measures that they used, so that you'll be able to know out of those outcome measures that we discussed and others that we didn't discuss, what did they use to be able to see if there is an improvement in the patient or not. Then you are going to see the intervention was given. So I was looking for the one that share that one that has pictures, so that you'll be able to see how they place the electrodes in the spine of the patient. Yes, okay. So this is one of them. Cutaneous spinal cord stimulation restores injury. Our findings demonstrate that non-invasive stimulation of the spinal cord restores movement. Yes, our findings demonstrate that non-invasive, so this is not invasive, it's not the one that you do surgically. You place them in the stimulation of the spinal networks, restores movement and function of the hands for people with both complete paralysis and long-term spinal cord injury. So if you read it, you'll see how they use neuroplasticity. Look at it, neuroplasticity. Perhaps most striking is that all 6 participants maintained their gains for at least 3 to 6 months. Remember, we said with motor learning, it has to be sustained. And they showed that with this, it was sustained. It wasn't just that they gave it to the patient, they improved today, and by tomorrow, it's gone. No, it was sustained for 6 months beyond stimulation, indicating functional recovery mediated by long-term neuroplasticity. So that is it. So this is the picture. And it's simple, not expensive. You apply it. I can see how they are encouraged to do activities of daily living while the stimulation is going on. So the same thing. You need to look at the participants. You see, this one is small number, and that's why I told you during the last week one that there are some studies that have started to show that the interventions are promising. Some have gone through full RCTs with appropriate number of participants, but some are going through the processes. But I'm just showing so that we'll be able to know what are those things that are out there that we can be able to use in our practice. The mean age of the participants was 42 years, 28 to 62. And therefore, if your patient is within that range, this is something that you can apply to them. And the meantime, since their injury, this is another very important thing. Is your patient within that range? 4.6 years is the average, meaning from 1.5 years after the spinal cord injury to 12 years. So meaning it's something that if you have a patient that is even 10 years after spinal cord injury, you can use this for them and you will still see improvement, just like they showed in this one. So this is how to apply the transcutaneous electrical spinal cord stimulation. They used the machine that they call, I think it's there. You see its details and how to apply it. You can even see the parameters used. We use an electrical current waveform for transcutaneous spinal cord stimulation that was either biphasic or monophasic. A 1 millisecond pulse width, 30 Hz base frequency with a 10 kilohertz overlapping frequency. See the information, the sensing functional task training tasks they ask them to do. This transcutaneous, say upper extremity move, and 2 hours per session. We use of intensive, progressive, following a protocol. The of repetitive upper limb movement, isolated performance, simple and complex pinch and grip performance. For each category, 8 to 10 activities with various difficulties performed, 1 to 2 activities within each category. In each training activities, this was applied, and it was also stimulating the more impulses to the muscles. With that, they got improvement in their upper limb function. You can see the outcome measures they use. One of them is that Asia. There is grasp that I showed you, something similar using a box that I said is just about $50. But this grasp is more advanced. I think it's when I looked at the amount in exchange in Naira, it's almost 1 million. But this is what they used to assess the patients. They also used modified Ashworth scale to assess for spasticity. The results are there. So I'm just showing these articles because what we did last week, I was the one extracting and just showing it in a PowerPoint. But we didn't have time to go through all. And I thought if we're able to now just show how you can be able to get the article, how you can be able to search and extract and understand how to apply it, you can be able to now take it and apply it to your patients because in our clinics. And to search, if you have attended that evidence-based practice that we did, all you need to do is, for example, to say transcutaneous spinal cord stimulation and spinal cord injury and hand function or arm function. And it's going to come up with articles, and then you download, you go through, and you'll be able to see what did they find. That's the first thing. Because if they said it's not effective, there is no point going further. But if they said it's effective, then the next thing is to find out who were the participants. Are they similar to my own patient? Then the next thing is to look at what they did. How did they apply it? And this is it, intensive functional task training, and then the transcutaneous electrical spinal cord stimulation. And then after that, what happens? What was the result? Then you'll be able to monitor outcome measures. What were the outcome measures they used? Because you need to use similar outcome measures also to be able to see if the patients will have the improvement that was recorded in the paper that was used. So this is just one of those papers. Please, I have a question. Some spinal cord injured patients have sensory disturbances. What are the specific physio interventions that could be employed to help in alleviating their problems? Wonderful. If you are here with us last week, we discussed about sensation, whether it's stroke or it's spinal cord injury. In applying the interventions. What is important is that what you have lost, you want to send message to the brain, and if it can't capture it, then neuroplasticity. We discussed the issue of proprioception, where you put the hands in the box and someone will move it and the patient will follow with a compass. So that bombardment of the information to the somatosensory area will help in neuroplasticity. But this time around, it depends on the location of the injury. If it is in the brain, then the neuroplasticity will occur in the brain. If it is in the spinal cord that there is an injury, that the impulses sent up to the somatosensory area is not passing through a particular level, then neuroplasticity can occur at that level itself and send the impulses up to the brain. So even if you have spinal cord injury, that's what we said earlier, you can have neuroplasticity, and doing the movement, you move the wrist, and the patient is expected to move the compass to align with the wrist. If he does it correctly, fine. If he doesn't do it, you remove the cover, he sees it, he corrects it. If you keep doing that over and over, impulses are going, they can't connect, neuroplasticity is going to take place. Now, the same thing with sensation. If you have a problem with sensation, similar to what we did in stroke, those interventions can be used. Remember the pneumatic compression, remember the tactile tractor, C5 tractor, and a number of other gadgets that we use there can be used to help with improvement in sensation. And there are a number of other interventions that we commonly use in the clinic, even transcutaneous electrical nerve stimulation, because if you apply signals about the sensation of stimulation, and in the brain that you have injury, facilitate and clear the pathway. As we explained last week, and the intervention. That is why a problem, you can still be able to use those concepts to treat sensory problems. I think I'm not going to, there are a number of articles that I have. We have done a lot. We may not really be assimilated. If there are any comments or questions, and remember some questions that I've not attended to. So while you are sending old ones. Paraplegic patient and also with involuntary lower limb movements. Remember, I told you for spasticity, there are two concepts. Number one, you want to use the interventions we use, the eyes, you want to use sustained stretching, you want to use a number of other interventions that we have been using to help reduce and relieve that stretch reflex, because there is no inhibition from above to a good one. So functional electrical stimulation, the joint.
That's why it says the person should go with
electrodes, Chidima, Victory. So you locate your electrodes strategically joint in the muscles that move the joint, and you ask stimulation that they should do the movement that will stretch. So because you are stretching it to the brain, and the brain impulses down if they are making the effort, because that is what the brain will understand, that they are making the effort. That helps in giving a more permanent solution than just trying to reduce activity in the reflex arc or peripherally when the brain is not. You need the inhibitory impulses to come down, and therefore you need something that is going to target the brain. Yes, does that mean if a patient had cervical spinal cord injury is an upper motor neuron? Well, that's not just it. When you have at the conus, below the conus, it's definitely a lower motor. That's what it's saying. But if you have above the conus, even if it is a cervical, what will determine whether it is lower or upper motor neuron is what part of the spinal cord does it affect. If it affects the anterior horn cells, then it is a lower motor neuron. But if it affects any other part of the spinal cord apart from the anterior horn cell, then it is an upper motor neuron lesion. If you remember when we were doing systems review, and we said some of the questions you asked during history to help you narrow down on a category of condition, we said, asking the patient whether they have mental status change. And I said, if they have mental status change, definitely the problem is in the brain. But if they don't have mental status change, it could be in the brain, it could be in the periphery. If it is in the brain, then it means there is a problem, but that does not affect the prefrontal cortex or the temporal area. That is why you are not going to have mental status change. But it doesn't mean that the problem is not in the brain. But it could also be in the periphery, so you don't know. But in as much as you have its mental status change, attention, recall, memory, information processing. If you have that problem, then definitely there's a problem in the brain. So the same thing with this. If you have spasticity or flaccidity, you know it's an upper motor neuron lesion. Definitely it is not a problem that is at the lower level, the conus, that's as you have said. But if you have a problem in the conus, you are not going to have spasticity. Definitely, you are not going to have spasticity. But anything above that, it could be upper motor neuron lesion, it could be a lower motor neuron lesion. What will determine which one it is what part it affects. Affects the anterior horn cells, lower motor neuron. Affects any other part of the spinal cord, upper motor neuron lesion. How can we use 6-minute arm test for a spastic or flaccid upper limb in tetraplegic SCI PT? How can we relate the result of the outcome to physiotherapy management? Now, you know there are outcome measures that the situation of the patient will determine whether you can be able to use them. Remember, I said you want to assess for sensation, but the patient has cognitive problem. You say, when I touch, say yes. They don't even understand what you are saying. Can you use that test? You can't use that test. You have a limitation because you have, so maybe what you do, you ask for, you wait until the patient's cognitive impairment changes, that he can be able to respond, or you use investigations that don't require the patient's cognition. If you can't do that, then maybe you ask for radiological investigation so that you now look at the sensory system to see if there is any injury or disease in the sensory system. Then you'll be able to say that, yes, this patient has, but there are limitations. So the same thing with the 6-minute arm test. You have a patient that has severe spasticity or flaccidity, they can't be able to move. Remember, they gave categories of people ranging from the use of the wrist to a number of other conditions. So the same thing, if you have severe spasticity in the wrist that you can't be able to even open it and hold onto the machine to do the activity, then you can't be able to use that. You have to find another way of assessing for the cardiovascular status of the cardiorespiratory status of the patient. Okay, so I think these are the questions that I have so far. Patients have sensory disturbance, what specific intervention is that? Okay, so I think I've answered the questions at least that are there on the platform. And in the absence of any hands, I can't see any hand, I can't see any question. I will hand over to the admin to give us a closing. I don't know if Dr. Samani is there. Over to you. If you're not there, Hafiz, over to you. Thank you so much, everyone, for joining us today.
Thank you so much, sir, for this long lecture. We are grateful. And to everyone, thank you for joining us today. To next week for the final module of the neurological physiotherapy, that is Parkinson's disease. The materials will be sent to the group, and certificates will also be sent to each and every